I'm just cloud recording, guys.
No problem.
Sindhin, welcome.
Yeah. Thank you.
All right. Saqib, do you want to go ahead or?
Yes.
Sindhil, shall I take the scenario or do you want to take the scenario?
Yeah.
Saqib wants to finish up the previous session. I think last session we had some endocrine.
Okay. Yeah. Do you want to take that? Finish it? Then I will, in the meanwhile, I will quickly finish my last part of my dinner.
All right. Okay.
Thanks.
Yes, Saqib, I'm happy. Ready. I have to. This is going to be Viva or like a short case?
Sorry. Do you want me to continue with the thyroid or what do you want? Or you want to continue with the emergency cases?
No, you said we'll finish our first thyroid and then we'll start with this thing.
Okay. So, Senthil, it is for you. Let me find out my presentation. Just give me a while.
Prepared specially for me. I don't remember the last time I did a thyroid case or saw a thyroid patient. But
do you want to do Prasidya?
Yeah, no problem.
All right, okay, no problem. Go ahead.
Saqib's very keen to make sure he drills me on thyroid.
No, it's just a last leftover case. We just wanted to finish the endocrine. It's very straightforward. Okay. But just let me find out where it is actually. 2 minutes. So it will be it will be neither a long case nor a Viva case. It will be a short case of maybe 10 minutes discussion, right?
All right. Okay. 10 minutes discussion.
Yeah.
Sure.
Just to make sure that we discuss it in a proper way. So can you see my slides?
Yes.
For the last
video.
Let's go to the last case. So Senthil, you have a patient who is 63 years old male. He presented with the obviously enlarged neck swelling in your clinic. And you are a general surgeon. How would you assess this swelling?
So first I will introduce myself to the patient and take a thorough history related to the swelling in terms of onset, duration, and progress. History related to any complications that I may anticipate in the swelling, such as any pressure symptoms, any difficulty breathing, any change in voice. And I will ask him for features of, on history, ask for features of either hyper or hypothyroidism, rule out any endocrine excess or insufficiency. And then along with that, general history to assess his fitness in case he needs any procedure. Family history and history suggestive of any etiology that may indicate thyroid disease, any radiation in the past, any family history of malignancy. And also, once I'm happy with the history, then I'll go on to the examination of the patient, start with the general examination, concentrate again on features of any hyper or hypothyroidism, check the blood pressure very carefully, just in case this is associated with any other endocrine, any other neoplasm along with thyroid. And then go on to examination of the thyroid swelling, in which case I will be looking carefully as to the extent, whether it's on one side or both, and If it's obviously very large, then I'll try to look at the retrosternal extent, try to look at, again, for pressure symptoms, try to identify the carotid. Look for any obvious lymph nodes that are possibly around the cervical area, left supraclavicular lymph nodes. And yeah, I think those are the main things. I'll also look for thyroid eye signs and see if there's no obvious hyperthyroid disease. Then I will go on to investigate the patient. I'd like to start with some blood investigation, especially concentrating on the thyroid function tests, see if they're normal, and then investigations for imaging the thyroid swelling. Of course, this also depends on what my clinical examination, palpation of the swelling, look for any firm or hard nodules.
So Santil, this man is saying that he doesn't have any change in voice. This swelling is progressively enlarging over the years, around about 5 to 10 years. He hasn't seen any abrupt increase in size of the swelling. But he does describe that while the swelling is the swelling as it has grown so much that it sometimes give him difficulty while swelling. That's the only complaint he has. He doesn't have any palpable lymph nodes. The swelling is quite enlarged in front of the neck and extending right till the sternum. The swelling has has a mixed feature. Some areas are smooth, some are bosselated, and you are not sure about it. There are no enlarged lymph nodes associated with it. What are the investigations that would you like to do in such kind of swelling?
In such kind of swelling, with relation to the thyroid itself, I'd like to image the thyroid with an ultrasound. Look for, with the history of 5 to 10 years and progression with no rapid change, apart from the dysphagia, I will be less concerned about malignancy, but I'll still need to rule it out. Look for ultrasound features, and possibly this patient will also need an endoscopy to look for whether this is just pressure symptoms from the thyroid or in fact there's any other cause of dysphagia. The other investigation, like I mentioned, the blood tests, and then depending on the ultrasound, whether an FNAC can be targeted to a particular area, if any suspicious nodules are there. If not, I would probably think of a picture of multinodular goiter with such a long-standing history. And also assess possibly the vocal cords with such a long history. Prior to, in case this patient's going for surgery, just make sure his cords are okay, because the larger the goiter, chances of any post-operative vocal cord palsy could be higher. I'll keenly look for stridor, because if it's quite large, then that's another problem. And post-operatively, I can go in for tracheomalacia as well. So that
right. So Santil, the GP has already requested few investigation, which includes some blood investigation and chest X-ray. These are in front of you. What is your interpretation?
Right. I'll just interpret the blood test first. Look like his T4 levels are within the normal range, closer to the higher part of the normal range. T3 is fairly in the normal range, and the TSH levels are also normal. So I think it's a normal thyroid profile. Consider this as normal. And the X-ray, one second. So it's a chest X-ray, AP view, and one thing that definitely stands out is the deviation of the trachea towards the right-hand side. Apart from that, so there's possibly some retrosternal extension of the thyroid.
So how would you what do you think? What is the diagnosis with this history investigation and the limited investigations you have available?
I think I would have to say, from clinically, my opinion would possibly be multinodular goiter. That would be my first. That would be my primary diagnosis. Like I said, differentials is very difficult clinically say to rule out any focus of malignancy in this. But that I will depend on my ultrasound for that, if it does show any areas.
What would be the aim of an ultrasound? What are the features that you if you have, you will think that it might be a malignancy?
So on the ultrasound, I'll look for any obvious well-formed nodules that could be hypoechoic with vascularity and possible surrounding rim or capsule. I'm not sure about that. And look for any microcalcification. And yeah, and also on the ultrasound, look for, might be able to see pressure symptoms, make sure the carotid is okay, and any lymph nodes. Are there any lymph nodes on the ultrasound examination of the neck along with the thyroid? Lymph nodes
Excellent.
could also suggest possibility of.
So you said the multinodular goiter. You think that it's a multinodular goiter. If I have to correct it, I would say it is a euthyroid multinodular goiter with a retrosternal extension. It's a quite a big goiter. What do you think? What are the causes of multinodular goiter?
I think the common ones would be iodine deficiency that leads to diffuse enlargement initially, and then the long-standing course, it becomes multinodular. Apart from that, multinodular goiter could be so any other causes of iodine deficiency would be dietary causes. If there was any antithyroid medications that were taken, I'm not sure if that particularly causes multinodular goiter. And otherwise, whether it's primary underlying malignancy causing multinodular goiter. I'm not sure.
Can you tell me the blood supply of a thyroid gland?
Yeah, the blood supply comes from superior thyroid artery branch of the external carotid and inferior thyroid artery, which is branch of the second part of the subclavian.
Okay, so
and the branch from the directly from arch of aorta, sometimes small branch thyroid area.
Right, so Santil, this ultrasound just shows few nodules, but there was no other associated feature as you have described for malignancy. And the patient has a compressive symptoms, and you have decided that you will do a total thyroidectomy for this patient because of this multinodular goiter, cosmesis, pressure symptoms, and so many things. Can you tell me what would be your preparation before operation? How will you prepare this patient, and what approach you would like to do in such kind of a big multinodular goiter? This is my last question.
Okay. I think my main concern in this case would be respiratory distress during or after the operation, and possibly that could end up in the patient requiring a tracheostomy. I think that's the most important thing I will counsel this patient for, apart from the other risks of the operation. I definitely have to counsel for risks of voice change, possible vocal cord palsy. So the reasons for respiratory distress in this patient could be multifold. Potentially tracheomalacia from the pressure symptoms, could be because of damage to recurrent.
Can we stop here? It's 10 minutes, 30 seconds.
Great. Varun, do you want to add any question?
No, first let me just review the things and then we'll go ahead. Okay. Sendil, just we'll discuss things like the first motto of this session. I want to make things still more perfect rather than just trying to be lax. If are you happy with these things? Like, shall we make it as more exam oriented?
Yeah, definitely.
Like we all know that we know the subject. We know the subject to such an extent that we can tackle everything. Shall we go ahead one step ahead and make ourselves more precise and more up to the mark for the exams, for the purpose of exam, I'm saying. Okay.
Yeah, I completely agree. You can fine tune things.
Yeah, exactly. The fine tuning things. Saqib, your scenario is perfect. First thing, Uh, I missed one point, Sendil. Did you say about the palpation of lower border of the palpation, lower border when the patient swallowed in the
No,
examination?
no, I didn't specifically mention that point. I
Okay,
said I will check
because
for retrosternal extent, but I
yeah,
did not mention that specifically.
the question itself, the scenario itself says that there's a huge swelling in the thyroid, in the front of the thyroid. So my aim will be to check, is there any carotid involvement, carotid bruit, lower border of the swelling is palpable, is the swelling moves with deglutition, check for hyperthyroidism, check for any hemorrhage, cystic lesion, nodes, and all these things. But more importantly, lower border tracheal deviation.
Yeah.
So that's the first thing which I noticed in the examination. And you said about the examination. I think the rest of the in the family history. This is my suggestion. I wanted to know whether can we say about in the family history? Can we say about any history of Men's syndrome in the thyroid cases?
Yes, I think so. But usually, I would think in a 63-year-old male, it would be unlikely because with men thyroid, it will present at 5 years and 10 years away.
Okay, all right, okay. So just family history. That's a valid reason. That's okay.
The family history, you can say that I will ask family history of any endocrinological diseases, any problems related with thyroid or thyroid cancers.
All right, okay, that's fine. Coming on to the this thing investigation. I think Saqib showed the X-ray, and the X-ray is there is an obvious deviation of the trachea in the X-ray. Did you mention about it? I didn't
Yes,
listen
yes.
to that.
That was the only thing I mentioned on the X-ray. Yeah.
Okay. I didn't listen to that because I was concentrating somewhere else. That's okay. And regarding the thyroid function test, always I think the thyroid function test goes hand in hand with thyroid peroxidase antibodies against thyroid peroxidase and long-acting thyroids. I think you didn't mention that.
No, I did not.
Okay. And Saqib was this is just fine tuning things. Like when we talk something, let's go ahead and say the things whichever is possible. The overall structure was good actually. I think the structure was perfect. There's no issues with the structure.
Structure
And
of
then
the examiner or the candidate? I was
candidate,
very vague and
candidate,
I don't think
candidate.
I was listening.
No, I think both of them are very good. Yeah.
Yeah. All right. Just these are the things let's go ahead and do some fine tuning things so that we don't we just make ourselves more unique. That's it.
Yeah. And one thing I'll mention for the retrosternal extension, you mentioned about CT scan or.
Oh yeah. And I'm coming to that.
Okay.
Second thing is, when you said about ultrasound, Saqib was asking about ultrasound. There's something called as complex cyst, cyst with the necrosis, hemorrhage, lymph nodes. You mentioned complex cysts. Even the complex cyst has got implication. The long-standing MNGs are more prone for follicular carcinomas and. I don't think you said about invasion, isn't it?
No, invasion on the ultrasound.
Did you say where did you say about the
capsule invasion? He said
capsule invasion.
Oh no, I didn't say invasion. I think I just said capsule. Like there was a rim around the nodule. I said I don't know if I said it.
I think it's more a histopathological thing.
Yeah,
that's a pathological thing. I felt like that you were mixing up something there. That's okay. Only thing is complex cyst in the thyroid, ultrasound of the thyroid says that it is a papillary carcinoma. Next thing is yes, CT scan. The next most important thing is CT scan of the neck and the chest. Without that, I don't think they go ahead and do any large thyroid here in UK. They wanted to know how far is it extending, and if it is extending into the thyroid, warned the cardiothoracic surgeons that they may be in need when there is a huge thyroid. We know that it is easy to take it out, but as a safety precaution, as a safety net, we have to mention that, I think. Coming on to the ultrasound, regarding the causes of MNG, Saqib, correct me if I'm wrong. If I'm wrong, there is a hypothyroidism at the childhood, and there is a fluctuation of the TSH during the adulthood, which leads on to the active follicles and necrotic follicles. The active follicles are between the necrotic follicles, and the necrotic follicles become cysts, and that is the reason for the MNG.
So I would say that the best way is that they divide into the causes into categories. The causes could be dietary factors, as he has said, lack of iodine. Certain vegetables do cause that. Long-standing history of hypothyroidism and Hashimoto's thyroiditis. Thyroiditis at the background of a decovenous thyroiditis. Possibility of malignant lesions. Possibilities of leukemias. So you can divide into...
Saqib, you are asking for the causes of MNG, isn't it?
Yeah, they are all causes of multinodal goiter.
No, in Hashimoto's, it is a diffuse thyroiditis. There's no MNG, there is no nodules.
So the thing is that whenever you have a state of a hypothyroidism, either secondary to Hashimoto's thyroiditis or any thyroiditis, there is a chance that the pituitary will secrete more TSH and some of the follicles may be activated.
If you go to the thyroid in MNG, in the cracking FRCS, you will see the causes of this thing.
Yeah, I can read it, but I'm very sure that that's how the mechanism develops. You have a goiter, which is under-secretory, as you have already mentioned, maybe iodine deficiency, certain vegetables, brassica-like vegetables, certain malignancies that take over the role of the thyroid, and then the TSH from the top starts secreting and try to stimulate the rest thyroid, and then these nodules starts developing. But yes, if you want the bookish answer, I can read it for you. Just give me 2 minutes, and meanwhile you can address something else. Yeah,
that's okay.
Yeah, I think what Varun is saying, that's more of the pathophysiology or the natural course of MNG, where that's the stimulating factor, and then there's varied areas of growth, and then it eventually develops multinodal.
It's multinodal goiter. That's it. And regarding blood supply, I think this is the inferior thyroid artery is from the thyrocervical trunk, which is the second part of the subclavian artery.
So yes, it is written like as
I did mention
in the cracking sentence. It is written as TS stimulation secondary to the lower level of thyroid hormones causes multinodal goiter, which includes iodine deficiency, which includes demand for increased thyroid hormone in pregnancy, puberty, and causing enlargement of the goiter. Dietary goitrogenous agents, rare hereditary congenital defects in thyroid metabolism also cause goiters. And then previous radiotherapy to neck lymphoma can also cause MNGs.
All right. Okay. I think that's the thing which I felt like things were missing. Few questions, I think, from the thyroid. What I could... do you have any... Saqib, do you have any other questions from thyroid? Just we'll quickly go through the Viva questions.
No, I don't have any. Just maybe post-op complications, they can be asked. But yes, if I have to give a comment, I think it was a very good... I will start with the positives. Positives were that the way you took the history. You see, Varun, last time I was telling that the thyroid or neck swelling history should be divided on the swelling history, progression of the swelling, more importantly, compression, change in voice, symptoms of malignancies, and hyper and hypothyroidism. And that was the best part. I really like that. But in the examination, I think similarly, the thyroid swelling examination is basically composed of two parts, the thyroid swelling itself and the examination for hyper or hypothyroidism, which includes, you will see blood pressure, heart rate, you will see palmar hysterexis, palmar tremors, and then the
This is
eyes are
breaking.
the examination that could have been included. Sorry.
Yeah, definitely. Should have been a bit
So
more
in this
systematic.
way, it could have, in this way, just like the way you systematize the history, examination could have been presented in the same manner. And then, as Varun has told, that the examination of thyroid is inspection, palpation, percussion, and auscultation, whatever it is. And that's all aus. And I think rest of the things are already highlighted. One thing I already have mentioned, that whenever we have a thyroid swelling, we and the figures are given, we should present it as a euthyroid, hyperthyroid, hypothyroid, and then multinodular, or with big swelling, or in this way. So I would say that this is a diagnosis which should be named as euthyroid, large multinodular goiter with retrosternal extension.
Yeah,
But
I
that's
completely agree. Have to have thorough diagnosis with all possible complications and everything. Diagnosis should include etiology and the thyroid profile and everything.
the rest was very good, very good. I mean, I
So
think I
to
I
summarize, I
hope I
think
don't have to do any thyroid in an HPB FRCS.
no, yeah, of course. I don't know.
It might come in Viva, but not a short case, hopefully.
Yeah, Sendil, I heard that from the last session,
Yeah.
they had thyroid in the what is this general surgery. So short
The
case,
short
as a short
case.
case, yeah, as a short case.
Okay. Okay.
So just to sum up, I think just a quick summary: history, onset of the swelling, how it progresses, how long the duration, onset, hypo or hypo symptoms, uh, pressure symptoms like dysphagia, dyspnea, dysphagia, hoarseness of voice, and malignancy symptoms like scalp swelling, any other swelling in the any bony swellings, and then hyper or hypoparathyroidism, any other neck swellings, including the secondary necks. Like it can be neck swelling from the primary can be oropharyngeal, nasopharyngeal, and this thing. And then history-wise, radiation to the neck and surgery, previous surgery in the same place regarding thyroid lobectomy, which can be secondary thing, secondary surgery, second surgery in the same, can be reduced thyroid in other terms. Examination wise, vitals, signs of hypo and hypothyroidism like palmar erythema, Dupuytren's contracture, eye signs, cardiac signs, and then examination as such, focusing on thyroid and consistency and lower border of the thyroid moves with deglutition. Then going ahead with the investigation. Apart from full thyroid investigation, I think calcium profile should also be included. Bone profile should also be included, including the thyroid function test and bone profile with TPO and TS LATs. Focused imaging in terms of ultrasound and FNA, ultrasound guided FNAC, and then classify the ultrasound guided FNAC under the Thai classification 1, 2, 3F, 3A, 4, 5, 6. I think it's 4, 5. And then, yeah, and then CT neck and CT chest. Then we'll come to a conclusion what exactly is the swelling, and then go ahead with the management. In the management part, management of MNG is total thyroidectomy. If it is papillary carcinoma, total thyroidectomy, and then go ahead with MDT, that's more important. First MDT, and then go ahead and do the surgery. PAP CA, medullary CA. I think we discussed medullary CA last time. Medullary CA, central compartment total thyroidectomy with central compartment dissection. If it is lateral, then unilateral or bilateral neck dissection. FRCS again, total thyroidectomy with plus or minus neck node dissection. If it is anaplastic, what next? RT.
Anaplastic, then this is a different ball game. Anaplastic mostly are locally advanced
Locally advanced.
or with distant metastasis. There is a role of
Yeah.
both radiation therapy and debulking surgery as well if there are a lot of compressive symptoms.
Yeah. Anything else? I think this will be the management and causes. Any neoplasm. I think they can ask for follicular carcinoma. What is the if it is a 3F, what will you do? If it is less than, if it is 3 centimeter single nodule follicular carcinoma. Takib, do you want to answer?
Yes, so any swelling which is less than 4 centimeters, especially in the follicular cases, you can do a lobectomy and a histopathological analysis. And if it is showed the follicular carcinoma, then it might require a completion thyroidectomy if the high risk features are present.
Do you want to do it at the same sitting or you want to observe?
So it depends. Even in the follicular carcinomas, if there are no high risk features, you can observe.
What are the high risk features?
Yeah, in cracking, there were written 3-4 high risk features. I'm not sure what were they in. I think differentiation is one of them. And there were 3 or 4 high risk features where you will give the patient an option of completion thyroidectomy.
Lymphovascular invasion.
Vascular invasion, capsular invasion.
Positive margin.
No.
Size
greater than 4 centimeter, vascular invasion, and capsular invasion. I think these are the high risk features.
Yeah.
With size more than 4 centimeter. If it is so, then go ahead and do the opposite side as well. Do you want to do how are you going to assess the? Do you want to do intraoperative assessment of this one, or do you want to do it otherwise?
So the otherwise, I would do intraoperatively. If the preoperative and intraoperative findings suggest that the lesion is less than 4 centimeter, I would go for lobectomy. But preoperatively, I will consult the patient that if there are high risk features present, as we have described already, then the patient might require a completion thyroidectomy. Or if in a histopathological analysis, the lesion is more than 4 centimeter, then the best way is that the patient should be sent towards a thyroid surgeon for a completion thyroidectomy.
Okay, now the scenario starts from here. This patient has had a thyroidectomy for a papillary carcinoma of the thyroid. So how are you going to proceed now?
Or papillary thyroid. Basically, I will discuss the patient in a thyroid MDT.
So this patient had the MDT says total thyroidectomy done, margins clear. There is one lymph node which is positive for PAP-CA. That is also clear. So how are you going to proceed?
So I will give a 2 weeks course of thyroxine to stop the central TSH stimulation, and then I will do a radioiodine scan, I believe.
Okay, radioiodine scan.
Yeah, to see that if there is any active area, any suspicious area. Then I will discuss the patient the options of radioiodine therapy, which can be given. This is my option.
So after discussion with the MDT, the principles of management will be keep the patient hypothyroid as much as possible, give recombinant TSH to make the TSH more than 30 so that the radioactive iodine uptake will be too high. And then you start with start giving radioactive iodine. That is, I think these are the things that are in even in the cracking. You ask the patient to take a capsule of radioactive iodine, 2 days isolation, and then I think these are things post.
Is it all cases recombinant TSH, or is the option of, because it
It is
always used to be
it,
option of
it
T3 T4 or recombinant?
no, it is for thyroid cancer. Any differentiated thyroid cancer after
Yeah,
the total thyroidectomy,
yeah,
any differentiated cancer needs
yeah.
to. We have to make sure that this patient is not prone for any recurrence.
Yeah. No. I know you have to do radioiodine scan. What I'm saying is preparation for radioiodine scan is usually one, either nothing, no hormones for 4 weeks if they can tolerate, obviously. One, two is 2 weeks of the leothyroidine,
Levothyroxine.
T3, or
Yeah.
recombinant in 48 hours. I mean, you give
So
the thyroxine for 4 weeks, but
usually,
recombinant.
basically in India, what we do is
Yeah,
we keep the patient off the thyroxine. So
yeah,
basically, we stimulate the TSH by keeping the by just not giving any levothyroxine. But in the cracking FRCS, they say after total thyroidectomy, give a levothyroxine and then also give recombinant TSH for 2 to 3 days before the radioactive iodine to make sure that how much of the iodine uptake is there.
okay, okay.
So, and then radioactive ablation include capsules. I think those are not, I think the most important thing, which what we want to know is radioactive ablation is given by just capsule isolation of the patient for 2 days, and then keep the patient away from the pregnant people. The mother is feeding, stop feeding, and if
Yeah,
the
there's lot of
yeah, a lot of all
specific points and
specific
preparation.
points like urine should not be flushed.
Varun,
Yeah,
I think, sorry, Sanjay is leaving, and I think he messaged on the chat asking whether a recording is possible.
yeah. I can. Yeah, I can send. That's the reason I'm just recording in the cloud. I'm not recording the. I'm not doing it in the this thing. We can.
So Varun, actually, I mixed the two different topics as well while the follow up, and you are also mixing the two follow ups. Because I'm right now looking at the cracking. So
Mm-hmm.
this question of follow up of a lady after a papillary carcinoma, after a thyroidectomy which was aimed for a papillary carcinoma,
Mm-hmm.
is a one question, which is a very separate question.
So this is what I'm talking about. PAPCA now.
Yeah, and the indication of a radioactive ablation is a very separate question.
Yeah.
So I think in my answer, I also mixed it up, and you also are mixing it up in the same way.
The follow
If
up.
Yeah, if the patient had a thyroidectomy for a papillary cancer and the margins are complete safe, the follow up is with the only thyroid hormone replacement, and then and 3 monthly, the cracking is saying that you need to get the thyroid functions to be assessed, and the
Mm.
thyroglobulin needs to be checked.
Yeah.
And if there are any concern, you can always request an ultrasound. This is one question, right? This is a one separate question. When
Mm.
I was replying to the answer, in the follow up, I don't know from where I took it to TSH and trying to get a radioiodine scan. This is not a follow up. This is only a follow up when you have a concern that you have a leftover disease, either locally or local recurrence, distally, or a
No,
distant.
it is not the rest over disease. It is actually rest over thyroid tissue.
Yeah, the other way, right? So these are two separate questions. For the rest of the thyroid, yes, you need a 2 weeks course of recombinant TSH, and then
No,
this capsule that you were already talking about.
2 weeks course of iodine, low iodine diet for 2 weeks, and then thyrox TSH.
Yeah.
Okay, 2 weeks low iodine, and then recombinant TSH, and then give iodine capsule for 48 hours. For 48 hours, isolate.
Yeah.
Okay, and then start with the other things like children should not be, and
Exactly.
then urine should be flushed twice, utensils should be rinsed thoroughly, and rest of the things are like caregiver should not be she should not be a caregiver for 25 days. So these are the
Agree.
things to be done for when the patient is on radioactive iodine. What is this masses calculator? Oh, I forgot this masses calculator.
I think it's all about the prognosis.
Prognosis, yeah. All right.
It is amps here.
Yeah, if it is follicular, I think we are it is differentiated. It is the same principle, is it? All right, Sendil. I think we fine-tuned ourselves.
Yeah. Can I just say, so my opinion, it is the approach and answers also possibly have to differ if it is short case or long case. In terms of the most important thing, I think is I've always stood by this is that we get the most questions from the examiner in terms of you cover the topics. Like, for example, if we spend history and examination on thyroid, it can become 10 minutes. And unfortunately, like even
that's what Sendil. If it starts from the post-op scenario, so we don't know.
What if it starts off the same way? Because so the question. I mean, I'm just saying. Just have a feeling. So in the exam, if this case particularly is multinodular goiter, then you needn't expand too much on. You to try to say whatever specific and needn't expand too much on the possibilities of the other stuff.
Mm-hmm. No,
I just feel because you should get your points for history examination. That will be one category. Then for investigations. Then for management. I didn't get to even complications. So if I possibly get to complications, I think I will score more than if I give a detailed history examination and time gets over.
That is what I'm saying. For example, if your scenario starts at the level of like this patient had multinodular goiter, had surgery.
Yes.
So how are you going to proceed? So in that scenario, we are going to start with the thyroid surgery, or for example, if this patient had a papillary CA and this patient is in your clinic, how are you going to approach?
Yeah.
So if I'm just trying to complete the session, complete the topic rather than
just
going in the same way, like history examination, and like we'll go ahead and do at different levels. We don't know which part we are going to get. It's not only the history examination and this thing. Saqib, happy?
Yeah.
Great.
Shall I?
Yeah, let's go on the next.
Let's go to the next. Yeah. All right, who wants to take up?
Yeah, I will take that.
Okay, Saqib, do you want to take?
Yes.
Sendil, are you happy to observe? Like
yes.
Comments from your side. I'll start the scenario. We'll make it a 30 minutes session. I will jump from one scenario to the other scenario. It is going to be emergency. Like 10 minutes. If you have your six sessions, isn't it? 6 scenarios, isn't it?
Six Viva. Yeah, 6. Whatever.
6. So put it 6, 15.
5 minutes each.
5 minutes each. Shall we do it like 3-3?
I think so. I think 3-3 is good.
3-3 will be so that we can discuss a lot rather than just jumping from one thing to other thing.
Sure.
Yeah.
Okay. Saqib, 3 scenarios for you and 3 scenarios for me or whatever. If someone wants to question me, that's fine. I'm happy. All right. Here starts your thing. Saqib, you have a 27-year-old guy who met with a road traffic accident. He was traveling at 60 miles speed, caught toppled. The ambulance crew brought him to the A&E. How are you going to proceed?
So I will assess this patient I will assess and manage this patient on the principles of ATLS. I will do my primary survey in which I will see the airway, assess the airway, and if it is a compromise, I will fix that first. And then I will go to the breathing, where I will see not only the heart rate, saturation, and also will do the chest examination quickly. And then I will go to the circulation part, in which I will see blood pressure, heart rate, and any obvious signs of
Okay,
bleeding.
this patient's heart rate is 120 and blood pressure is 70/40.
So this patient is in the kind of a grade 3 or grade 4 shocks. What I would do is that I would start resuscitating this patient again on the line of ATLS principle. I will put 2 large bore IV cannulas and I will take the blood sample
You gave him 1,000 mils of Hartmann's and still his blood pressure has not gone more than 70/40.
So I will activate the massive transfusion protocol and I will be worried for the.
So what is massive transfusion protocol?
Massive transfusion protocol means that I will activate my blood bank. This patient will need an emergency transfusion of a blood, likely with a ratio of 1:1:1, packed cell, platelets, and FFPs. And I will not wait for any cross-match blood. If I will prefer to transfuse O negative blood. If it is available, yeah. So that will be my transfusion strategy for this patient.
Okay. So do you want to say the criteria for massive transfusion?
So massive transfusion is required if the patient has lost all the blood, if the patient needs all blood replacement in 24 hours, if the patient has lost half of the blood volume in last 3 hours, or if the patient is losing the blood at a rate of 150 mils per hour, then these are the criteria that meet the activation of a massive transfusion protocol.
Have you activated a massive transfusion protocol in your hospital?
But not from my side. Mostly it is activated by the emergency personnel. Yeah.
So do you have any experience what the emergency people do in your hospital?
So in our hospital, the preferable transfusion is generally O negative blood group. If it is not available, then we can even work with the O positive blood group. And initially 4 packed cell, 4 FFPs, 4 platelets will be a start will be a good start for massive transfusion. Yes.
So what is the indication for O positive blood group in a massive transfusion protocol? What is the indication for O positive blood group?
So generally the O blood group is preferred, and among the blood group, O negative is most preferred. But if it is not available, then the O positive blood group, especially if the patient is not pregnant, yes, then you can give even O positive blood group as well.
Okay. If the patient is pregnant, for example, if the patient is a female patient and is pregnant, do you want to do any special blood test?
Yes, we can go for an Rh antibodies test. But again, if it is a first pregnancy, it doesn't matter. It mostly matters in the.
All right. This patient had a blood transfusion, and the massive transfusion protocol has been launched, and you transfuse, and still the BP is 70/40. So what will be your approach now?
So I will need to see where the patient is bleeding, and generally there are 3 possible sources: chest, thoracoabdomen, pelvis, or long extremities. Or
chest is normal.
Sorry?
Chest is normal. Chest is normal. Abdomen is distended.
So if the abdomen is distended and the patient is and the long bones are not source of bleeding and there is no external bleeding, obviously the source is likely in the abdomen. And if the patient has so much hemodynamic instability, I will go for a trauma laparotomy to control the bleeding.
Okay. So how do you do the damage control surgery?
So the damage control laparotomy, after completing the WHO checklist quickly for the trauma laparotomy, antibiotics, putting an NG tube, urinary catheters, and I will keep the patient on the kind of a crucifix table with both arms extended, and I will prep and grab the patient from the neck to the mid thigh, and so that the neck is accessible to the
So
anesthetic.
you WHO checklist done and you open the abdomen. What do you do now?
So I will make a generous incision from a Zifi sternum to pubis, and first I will do all four quadrants packing, and I will pack those in that area which is bleeding the most, and
Okay,
then
that's 5 minutes.
No, we'll go ahead. We'll go ahead.
Sorry to interrupt.
Up to
Yeah,
up
yeah.
yeah.
Okay,
to
just to let
Yeah,
you know.
so I will pack by counting with the scrub nurses as well. I will pack that area which is the site of which is the most which is most likely the site of bleeding first, and and then I will pack the rest of the area, and I will unpacking the area from that area which is less likely the source of a bleeding, and then we'll come onto the major site of a bleeding, and if it is still I'm unable to find out the source, I need to eviscerate the bowel to see that whether there is an obvious site of bleeding in the mesentery or retroperitoneum.
okay. You do a trauma. You did a 4 quadrant packing, and you feel like there's a bleeding happening from the liver. There's a huge liver laceration. So how are you going to proceed now?
So this requires definitely a damage control laparotomy and probably damage control packing. I will pack the liver in all four quadrants, which includes superiorly, laterally, inferiorly, and I will try to compress the volume of a liver. Then I will ask from my anesthetist whether it is working or not. There are a few other methods that I can always do, which means that if the patient is still bleeding, then I can do my Pringle maneuver. But whatever I do, I will see the response to my intervention.
Okay, you do a Pringle maneuver and you control the bleeding, and the anesthetists are happy that the blood pressure has picked up now. Are you going to remove the pack now?
No, I will prefer not to do so because this patient who has lost so much blood, their physiology must be altered completely. I will still pack the patient and temporarily close the abdomen with the Apthera bag and will send the patient to the ITU for the correction of the physiology. And once maybe in 24 to 48 hours, and once the physiology is within the normal limits, then I will take the patient back to the theater for a definitive approach.
How long after you will take the patient to a definite approach?
So it depends upon the correction of the physiology. My markers will be that his pH should return back to the normal or near normal. His lactate must be less than 2.5. His coagulopathy must be corrected, which means that INR should be less than 1.5. These are the parameters when I will start thinking of taking back the patient to the theater. And I believe that it generally requires a wait of 24 to 48 hours in ITU setting.
Okay, so this patient has been transferred to ITU, and the ITU says that he started bleeding again from the drain site and from the wound site. What do you
So,
think of now?
so it means that the bleeding that was controlled at the first place either was not adequately controlled or the patient bent into a DIC. Patient who had
Okay,
a
how are you going to confirm this is a DIC?
So for the confirmation of in the ITU setting, we all have available TAG scan, which will not only check whether the clot is being formed and will also give me idea what type of blood products needs to be transfused. There are
Okay,
other
how are you going to choose the blood products?
Sorry?
This patient had a rotem test, and the rotem test is positive. And what are you going to proceed? How are you going to proceed? How are you going to manage this DAC now?
So the management of a DIC will include basically a multi-level care, which means that the all the fluids that needs to be transfused should be warm. The patient should receive the blood products in a fashion of in the ratio of 1:1:1. And in the trauma setting, I will give antifibrinolytic agent, that is tranexamic acid as well. And these are the methods that I will take care. I will do for prevention of ADIC.
Do you have any criteria to transfuse the specific blood products in the DIC?
I cannot recall at the moment, but it is
Okay.
mostly
So
based on the tag result. And
okay.
tag tells you that whether the you need to transfuse platelets, FFPs, or packed red blood cells.
Okay. So post-operatively, this patient had a repeat laparotomy and the packs was removed. The patient is hemodynamically stable. After 5 days, the patient develops fever, temperature, and becomes septic. What will you think in your mind?
So the causes could be in such settings with such liver laceration, the patient can be going into an acute liver failure because of the loss of the volume of a blood, a loss of a volume of a liver. This is my first possibility, or other possibility could be any intra-abdominal collection, which can give rise to these fever or sepsis.
Okay, so this patient, you did a liver function test for this patient, and the bilirubin is rising, and the repeat CT scan shows there is a collection of size 10 cross 10 centimeter in the hepatorenal pouch. So, how are you going to proceed?
So for the causes could be either of the two. In the presence of a collection, my thought process would be it is likely intra-abdominal collection. I will keep the patient on a broad spectrum of antibiotics first, with them after liaising with my microbiology colleagues as well. I will send the blood for the cultures as well, and probably this patient will benefit with the placement of an intra-abdominal drain, and I will speak with my IR colleagues if they can put in a drain, and if the collection can be drained. But simultaneously, I will still liaise with my gastroenterology colleague and liver experts that whether the cause of fever is that the cause of fever may not be a permanent liver failure, which is a very common after a post trauma.
Okay, so this patient had uh, a ear drainage and had bilioma. So, will you think of anything? Do you want to transfer this patient anywhere?
So if the IR drainage is showing the biloma, then it might be then it's likely a damage to a bile duct biliary system. And if that is the case, then I would definitely like to send this patient to the proper HPB unit. Probably this patient will need MRCP to estimate
Okay.
the
So,
injury of the bile
you
duct.
you okay. So, can you tell me what is the definition for damage control surgery?
So the damage control surgery is preceded after a damage control resuscitation with an aim to correct the physiology rather than correcting the anatomy of a patient. And that is
What are the
generally,
where are the places we will do the damage control surgery?
so when there is in exsanguating hemorrhage and there is a contamination with the hemodynamic instability of a patient,
Okay.
I will do a damage control laparotomy, which means to control bleeding or to
So
control the damage.
do you see something in the screen? What is this?
So this is the unenhanced CT scan of abdomen coronal view, which is showing a large hypodense area in the liver with some air specks in that. It is giving me a suspicion that it is likely some collection at the site of a liver, and in this case, probably at the site of a previous resection.
Do you see anything else?
I could see that there is either a drain placed inside it or yes, but I need a few more cuts for the better delineation, but it looks like it's an intra-abdominal drain.
All right. Okay. What are the do you know any classification of liver injury?
Yeah, liver injuries. American Association of Trauma has classified liver injuries into 5 types. One includes the grade 1 laceration, which means the laceration less than 1 centimeter or less than 10% of subcapsular hematoma. Grade 2, 1 to 3 centimeter laceration. Grade 3 is when more than 3 centimeter of laceration is present. Grade 4 is laceration, any laceration with more than 3 centimeter, and the grade 5 is a shattered liver, where the involvement of a hilum of the liver is involved.
I'm stopping here. Sendil, I'm stopping here.
Yeah.
How was the drill?
It was very
minutes.
good. Thank you. It
No,
covered
that's
everything.
good discussion, of course. No, I thought you were going to stop every case at 5 minutes.
No. Sendil, I heard we have a 30-minute session continuously, and though they don't even remember the scenarios, what they get.
Okay.
So the Viva sessions will be 30 minutes continuous.
Yeah.
Every 5 minutes, they change the scenario.
Correct. But then it changes every 5 minutes.
But
the
here,
discussion won't go on.
No. But here, I wanted to change the scenario, but I change in terms of emergency continuously.
Okay, fine, fair enough. So that fine.
Do you understand what I mean? Like I went
understood.
into the
the TEG part
and
of
then
it,
damage
DIC part of
control,
it,
and then liver injury. So these are the three scenarios which I took.
Fair enough. Then that's perfect. That's my goodness.
It was very good. Very good.
You should be examiner, not taking the exam. I have no doubt after you clear this exam that they'll call you to.
So Varun, before we dissect this scenario, I would also appreciate it was a very good drill. It took me to different areas, from trauma to damage control to ITU management to tech scan. After
the input from the people, those who attended the exam, I want to prepare myself in a situation that how they experience, and we should not have the hesitation of these things. Like we should just crack on straight away, check. That's it. So not to keep thinking something. Like we have to drill ourselves in this way, rather than just stopping there 15 minutes, 5 minutes, rather than just go and do whatever. Saqib, perfect, fantastic. I think.
So. Well done. I'm definitely not going to concentrate on the theory points. Nothing. I think whatever it is, we have to read these topics in terms of TEG, DIC, from massive transfusion protocol. So I'm not at all going to concentrate on the theory points. My both query, please correct me wherever I'm wrong. So most likely this patient, with the scenario that you gave, would, like Saqib said, it was probably going to be, the scenario will probably be A&E calls you. So you're not going to be alone in this scenario. So I assume that you're going to have the trauma team with you. So I would confirm that, the trauma team is there with the anesthetist and emergency, unless of course the scenario specifically mentions it, because this is a patient who's crashing in front of you. The second thing is, as you go through A, B, C, D, E, it's always good to say each level that you've secured it. So airway is secured, breathing is secured, and only then you go. You're not allowed to go to the next level without, B being okay. You can't go to C. So, but I think you mentioned that, like you said, if the breathing's okay, chest is okay, then I will look at cardiovascular. So that was good. You really did well. Very systematic. I don't even know how to pinpoint things. But one, make sure the team is there. Two, I think Trenexa in this could have been mentioned in the first instance, along with the blood transfusion. When you mentioned massive transfusion protocol, I think Trenexa is mandatory, especially if it's within 3 hours. But I think it has to be mentioned. The third point is that when he said that it is, it's still 70/40 transfusion, I think even at the first instance, we should probably say that I'm suspecting this patient may need a laparotomy in case it doesn't respond to the blood. Because otherwise, of course, he led you on to the question of massive transfusion protocol, but then laparotomy is part of the resuscitation, as you rightly said. One comment about, so basically, I think when you mentioned the surgery and preparation, you said go through checklist quickly. So I think don't do that. The checklist is there, it's there. You have to go through it slowly. Because here, then that becomes an area of concern.
Before going into that one, I just want to...
I personally think, as you are saying, yes, I think that WHO checklist is not a good thing. but I mean, I don't know why probably it's written in the cracking.
No, no, yeah.
No. I'm
Just a
saying
second,
don't
just a
mention
second.
the word quickly.
Okay.
You said we'll go through the checklist quickly. You said don't just say we'll go through the checklist.
Okay.
Okay. Before going into that, Saqib, I wanted to add something. Uh, Regarding the massive transmission protocol, I was asking something regarding when do you give the what is this O positive. O positive is for 50 years, more than 50 years, not for females. And if you don't have O negative, more than 50 years male, and not for females, and not for pregnant women, for males. That's the indication for O positive. And regarding the packs, I think the massive transfusion, we had a discussion with Prashant. Do you remember? So massive transfusion, they have two kits in each and every hospital. They have two kits. The first kit has 4 to 5 PRBCs or pack cells, and they don't have FFPs or platelets or anything. And the second kit has all FFPs, platelets, and cryoprecipitate with PRBCs. So I don't think as a ATLS 10 protocol, you are right. Okay, 1:1:1. But is it followed practically in all the hospitals and all the trusts? Is no. So that is the reason I asked you, have you done the is the massive transfusion? Even in the cracking FRCS, they have mentioned the same thing. What Prashant said and what I am discussing. But ATLS, yes, 1:1:1.
So 4 pack cells in the first kit, and then the second kit.
Each and every trust has different things. Shakib, cracking FRCS says 5 PRBCs in one pack, pack A, and the second pack has got one platelet, one platelet. Oh, I don't remember now. One platelet, 2 FOPs or 3 FOPs, and 4 PRBCs something like 4:3:1:1 something. Just have a look at it. I don't remember now. So there are 2 packs in massive transfusion protocol. Pack A first and pack B second. Pack A doesn't have anything, only PRBCs, and pack B has all. And the indication for platelets and all these things are, when you do a coagulation profile, if the platelet is less than 100, and they transfuse one platelet to bring the platelet up to 100. And if it is, cryoprecipitate, if the text says that fibrinogen is less than 1.5, then you give cryoprecipitate. That is why I brought these 2 things, one in massive transfusion protocol and again in the DAC.
Yeah, TAG scan, I think it's...
Don't say TAG. Don't say TAG. It is ROTEM. That is what they will expect from you. Okay? If you say TAG, they may not know.
No, I'll say the complete form, thromboelastography scan.
Of course, we know that. This is the matter of verbalization. Were you in UK for 10 years? If you say ROTEM, yes, you are here for 10 years.
Okay. But what does the ROTEM say? So if the platelets is easy to remember, if less than 100, transfuse platelets.
Yeah, platelets. And if the fibrinogen is less than 1.5,
fibrinogen is less than 1.5,
then cryoprecipitate. Even in cryoprecipitate, they have two things. The cryoprecipitate is PPC4, that is, which is not activated, is PPC4. And if you don't have PPC4, is it PCC or PPC? Whatever.
PFC, no? Platelet factor 4 complex.
No. Platelet cryoprecipitate, something. PCC4 and PCC3. PCC4 is unactivated with platelets. And oh my God, I completely forgot. I think this is there in the cracking. I think you guys can read it. There are 2 things, PCC4 and PCC3. PCC4 is unactivated. PCC3 is activated, but it doesn't have platelets in it. Whatever. This is something.
Yeah, I think theory
Just
part we can, I mean, theory part, unless we say we prepare a topic and do it, we should just try and concentrate on the approach and the verbalizing and the
yeah.
systematic. So, but this is helpful. Like we can note down topics to, say that we have to read in theory, like massive transfusion protocol, road temp, etc. But discussing it, I think will go,
So
too much.
just to add up things to the like when will you give cryoprecipitate, when will you give platelet?
Yes, yeah, definitely.
So these are the indications for platelet. Have you got any massive transfusion protocol in your hospital? Even if you don't have, even if you don't know, if you say this, they will say, "Oh yeah, this guy has done some massive product." Nothing more than that. Just acting.
Yeah.
Go ahead, Chandil.
Yeah.
Sorry, I just stopped you. Go ahead with the theater.
Now. Yeah. No, before, I just mentioned the point about the checklist. I think it's very important. So don't say quickly. Let it, just mention it. So I think the thing with trauma is at every point, whether when the scenario is changing, it's about all the approaches. Now when the BP is 70/40, or it is either blood stabilize if stable, CT, then if unstable, laparotomy. So when we say it, I would say it instead of committing and saying laparotomy, even though he said now it's still 70/40 and you've transfused. So you'll say, I would say now I think there is no role for conservative management. Therefore, I'm going to consider laparotomy. Or say that at this point, I don't think it is safe to do a CT scan. Hence, I will consider taking the patient straight to theater. It adds to your points that you have thought about CT scan even in this scenario. So it is what you're doing is right, that the patient has to go for laparotomy, but it's just the manner of saying it.
Yeah.
I think
that you're ruling out.
You were struggling to say this damage control surgery.
Sorry?
Were you struggling to say that damage control surgery? You picked up some other word for this damage control surgery. I don't remember now.
No. I said damage control surgery will be preceded after DCR, damage control resuscitation.
Okay.
And so similarly, when he explained damage control very well. I mean, but again, okay, since we're on the point of damage control, so when you were asked about the physiology and correcting it, then it comes in the definition. I think specifically is correcting coagulopathy, acidosis, and hypothermia. Those are the main 3 advantages of damage control surgery. If they ask you a specific question. So coming to
this point, I even when I was saying, I picked it up that I should have brought this virtual stride, or what do you call it, triangle of death, in lethal triad. Sorry, not virtual stride, lethal triad or triangle of death.
Yeah.
This is the one part, and I also thought that in this type of case, I also should have taken into account the role of an post-operative IR, because these sort of complex injuries often require both approaches: surgery with an IR to selectively angioembolize in any hepatic artery territory.
So that was my next point, that basically even post-operatively, despite of course seeing blood there, the DIC is the most important thing. I think you will rule out. But one, is there a role for CT scan? Is there a role for IR? And is there an indication for re-exploration, or whatever it is? So again, put forward your point in terms of, at this point I would like to do a CT scan, but as the patient is blood pressure is falling, or as the patient's whatever coagulation parameters are deranged, I would like to correct that, and if the patient stabilizes, then do a scan. And I would like to do an arterial phase scan, ideally, to see if there is a possibility of embolization. If this is not the case, or if embolization is not available, then I will go for whatever relook or whatever can be. So that is that. So yeah, I think that was all the points I've written. Like I said, I didn't want to concentrate on theory, just the approach.
Uh, Sakib, you didn't involve any of the team members at any point.
Sorry?
Yeah, that was the first thing I said. The emergency team anesthetist.
No. So the thing is that when you were giving a 5-minute scenario, I tried to use the precious words.
Yeah.
So when I said that I would manage on the line of an ATLS principles, then it automatically has this word. I mean, the trauma team, because ATLS doesn't start without the trauma team. So because of the time limitation, I wanted you to take.
Yeah, no, that's fair enough. That's how it should be.
That's fine. That's fine. But how was like 5 minutes? It looks like too quick, isn't it? Like the time will run. I think probably it will run like anything.
Yeah. It will. That's why I think. I think Sakib did very well to be, just the right amount of balance of answering, then waiting for you, and you also change the scenario at the right time. So I think we got a lot of discussion.
As and when Sakib was saying things at the right direction, I just don't want to keep him going on into that.
Yeah, and that's how it will be or should be, I think. So.
Yeah.
So this is. Can you see the screen?
Yes.
Yeah. Sakib, the thing is, the most important thing here in ROTEM is, I don't think they will ask what is ROTEM, how are you going to interpret and all these things. But what I wanted to say here in the thing is, I know TEG and ROTEM is same. Okay. I think there is some slight difference between TEG and ROTEM. There is some needle rotation. I just had a look at what is the difference between TEG and ROTEM. What they do in UK is ROTEM, I think.
Are they not the same thing? Are they not a synonym?
No, there is a slight difference. It's a technical difference. Like in one, the needle rotates. The other one, the paper rotates. There's some technical difference.
Okay.
I don't think we should dissect this difference.
No, I know that. That's why I didn't come into that area. But I will share you with.
I don't think you will lose points for saying TEG or ROTEM. I guess it depends on the examiner and what they're used to, like you say. but if they ask specifically, is there any other name, then I'm sure you know.
Yes, exactly.
Otherwise, I don't think you will lose.
Yeah, exactly. That's what I wanted to say again. I don't want you to go into that, but I had a look at it. Like, what is the difference between TEG and ROTEM when I was preparing for this? I can't go ahead without knowing what is what. That's the problem,
The only concept that I had, which is easy to remember, is that this test gives you an idea which blood products needs to be transfused, to be honestly speaking.
Yeah, TEG versus ROTEM. If you put TEG versus ROTEM in your Google.
So you see that in this figure, because this is the only idea I have. Or you always forget when you have a problem with which time what you need to transfer. Always forget. But the only concept that I have with this test gives you on certain parameters an idea that which factor you are lacking in the patient at the moment.
Yeah. Just have a look at my screen. I think I'll show you my screen.
Okay.
This is what they say about TEG versus ROTEM. Do you see my this thing? A pin is suspended into the and ROTEM is bit which rotates.
Okay.
Do you see that?
No, I can't see.
No, still got Sakib's.
ROTEM versus a pin is suspended into the cup and then some sort of rotation takes place. In fact, the main difference between TEG and ROTEM is the bit which rotates.
Okay.
So TEG and ROTEM is not same, but there's a slight difference. But both give the same same inference. But what they do in UK is ROTEM.
Okay. Thank you.
Just to that's what Sakib. What we are going to say is more important because I don't want we to be different from the other people, like the trainees. We have to be more similar to them so that they should not have any idea of is this a guy a trainee or non-trainee?
Yeah.
Yeah, no, absolutely. Another thing that may help. I don't know about how much guys you have access to the deanery teaching at your places, but
Nothing, nothing, Sandeep. I don't have anything. They don't do at all. First of all, in Wales, there's no deanery teaching
okay.
at all.
Oh, is it? Okay, okay. No, because like here, the trainees go for the deanery teaching, right? So every now and then I keep telling them to let me know, what's the topic and what's. So sometimes they have like practical sessions, basically FRCS prep, and even though they're just trainees at ST3 level, ST5, 6, 7, everyone. So it's very it's really different the way they speak, the things the things they say in the scenarios. Even if they don't know the answer, they will manage to attempt the scenario just like they're talking to a consultant in the corridor. It's like that. So yeah, what you say is right.
Yeah, that's the thing. That is what like we can try to practice
I
as
think
much as possible.
I think we cannot. I mean, we cannot afford to go in details of this because it is obvious,
No,
Senthil,
no.
that I mean,
Yeah, yeah,
you always score good at your home ground, right? So for the
yeah.
deanery and for the trainees, it's just like a home ground. I mean, I'm sure if I take them to Pakistan or India to give their exit exam, they
No,
will struggle.
Not
They will
struggle.
they will definitely struggle. They won't be able to answer them.
They'll commit
So
Nothing will
suicide.
be a struggle. It will be a whitewash.
yeah. So the only thing is that it's not our ground. The pitch is not ours. So it's all we need is
Yeah,
to
yeah. That's why we'll work on it in these
yeah.
sessions.
All right.
What's next?
Then what else? Perfect. I think Sakib, it was a quick run because I just wanted to finish off the scenario, three scenarios at different levels. Shall we go to the next?
Sure.
Yeah.
Another three sessions, three scenarios, like a consecutive scenario. But I don't have the images, but I can do it. Do you want to do it, or I can? Someone can ask, or we'll split into two. I want to do something myself as well.
So Varun, if you want to
Yeah,
do, would you be happy that just attached to this kind of environment where we are discussing damage control laboratory, I can just give you a 5-minute challenge, 5-minute
Yeah.
case.
Okay, all right, no problem.
Just a 5-minute case, and let's see your approach. It will be very similar to this trauma type of scenario, right?
Keep it as 10 minutes so that it will be right.
Yeah.
Okay.
Yeah. So Senthil, you will observe him, and I will present him a scenario. So Varun, you are a consultant surgeon in the hospital, and one of your orthopedic colleague who was doing total hip replacement in an elective setting called you in an emergency because he is unable to control the bleeding. He has tried all his methods to control the bleeding, but he is unsure where the blood is coming from. And you are a general surgeon on call, joining him. What approach you would do? The patient is in a semi-supine position with the right side up, right? You can say that it is a lateral position, but not a typical lateral position, but a slightly right side up, right? How would you approach this patient who is bleeding, who in the field of total hip replacement surgery?
Okay. Being a consultant surgeon on call and on the way to the theater, this patient supposed to be on the theater on table, anesthetized with the anesthesia team and the
Everything is there. There is a
so
chaos.
considering all this in my mind, the patient had total
Varun, I want to give you input. So yes, everything is ready, but everything is in a chaotic state. Anesthesia is calling to their technicians to bring bloods, and there are a lot of people there, and it is full crowded.
Okay, so my thought process will be a major blood vessel damage, which is an ongoing first thing. Second thing will be a possibility of DIC. After reaching the theater, I would have a look into that. Is it a diffuse bleeding all over the incision site, or is it a particular arterial or venous bleeding? And if it is, I will just pack it and check whether it is a diffuse bleeding or particular arterial bleeding. If it is a diffuse bleeding, I'll think in terms of DIC. I'll ask the anesthetist to send a coagulation profile, urgent coagulation profile, to make sure what is the hemoglobin, and also check how much of blood has lost at that particular time. Check with the nurses how many packs has been removed, how much of the blood has been sucked out, check the blood loss, check the blood pressure, how far the anesthetist is happy with the transfusion. Is there any transfusion done intraoperatively with these things happening? And then considering all these things, check my approach would be differentiate between the DIC because of the massive blood loss. Second option is there any major blood vessel damage? If it is a DIC and things, I will ask the major transfusion protocol, check with the hematologist, check the coagulation profile, and go ahead in that pathway. And if it is a blood vessel, if it is a major blood vessel, I will pack this area and I will try to control the bleeding proximally. If it is a major blood vessel, vein or arterial bleed, the better control will be from the proximal. It should be external iliac or the internal iliac.
So Varun, let me give you the figures. So the patient has a current blood pressure of 100/80 and a heart rate of 140, and the patient hemoglobin on the ABG is 875, and you pack the area of the surgery, which was around the right hip joint, but the pack soaks very quickly. And when you try to remove the packs, there is a bright red blood coming from, but you are unable to localize that which artery is bleeding.
Okay, in that scenario, if I'm not able to, if it is an arterial bleed, if I'm not able to localize the artery, the best way to control the bleeding is to have a proximal control over this area. I'll pack this area as much as possible, put a tie, and keep the patient, change the position to the supine position, paint drape, and make an incision in the right line, do the Morrison incision, go retroperitoneally, have a control, dissect the retroperitoneal area, and localize the external iliac artery and external iliac vein.
So you took a control of external iliac vessel into a vascular loops and try to snug it, but still the bleeding is not stopping. What would you do next?
It's highly unlikely to be an arterial bleed, or it could be something from the proximal area. Still, if it bleeds, it could be from the internal. No, it can be from the internal. It could be from the external iliac if there is no control.
So you had taken a control of external iliac artery, but the patient still bleeding. The packs are still getting soaked. What would you do?
I will transfuse. I don't have a clue what could be the next approach. If it is so, then it is not from the if it is not from the arterial or venous bleed. It should be both. Is the control both arterial and venous control done?
No. So the thing is that right now the intervention that you have done is packing, and you have got a proximal control of external iliac artery, but you still say that the packs are getting soaked very rapidly.
Okay, if it is so, then I have to think of is this a venous bleed which is happening? If
it is filling of pool of fresh red blood, very unlikely venous blood, and it is the field is full of bright red blood.
Is there any other possibility of any other blood vessel which is going on there is less likely apart from femoral?
So yes, you tried to see that area while you were exploring to see whether it may not be any muscular perforator, but you couldn't find it. The whole area is just red, bright red, full of blood, and whatever packs you fill, they get soaked very rapidly. And you have a good control of external iliac artery. What would you do next?
Mm, I don't have a clue now. Stuck up here.
But this scenario can happen. This scenario can happen.
Because if it is a hip replacement, the only artery which could be damaged is extrailiac femoral artery, profunda femoris, and the venous drainage. Veins can be if it is a venous drainage, we have to get a proximal control of the vein. If it is arterial,
Internal iliac branches.
Internal iliac will be branching one to the pelvis. They don't get into the hip area at all.
No, but branches of the internal iliac.
Branches of internal iliac is
lumbar arteries. Lumbar arteries. I was just thinking lumbar arteries, lower lumbar arteries from the
lumbar
back.
arteries. No, lumbar arteries. They just go into the.
No. The vessels that supply from the posterior lateral abdominal wall.
No, I don't think so.
Why can't they be? Because we know that at the hip there are two types of what we call circumflex anastomosis, right?
Okay, whatever the arteries. Like coming on to the anatomy of the hip. Hip anatomy is basically anatomy of the hip. The blood supply for the anatomy of the hip is circumflex artery around the hip, which all these things are from profunda femoris and the femoral artery.
So there are
artery. And the other arteries in the hip are superior and inferior gluteal arteries. Superior and inferior gluteal arteries are again from the internal iliac arteries. Arteries. It is iliac arteries. So we have control over that area. So pack that area.
No, but only external iliac control you had, right? That was the thing.
So I have to go ahead and still more proximal.
Okay, so yes, so
I think irrespective of deciding whether it's the correct answer or not, I think you have to decide what is your next step.
Let me continue that. Yeah, so you decided to take a more proximal contour of a right internal iliac artery, and you managed to put your vascular loops around it, and then you, with the orthopedic colleague, reassess the area, but it is still bleeding. It is still bright red. Packs very rapidly get soaked, and the anesthetist is saying that the patient still has a tachycardia with the blood pressure 80/40. The repeat blood gas show hemoglobin of 85. You have blood coming up, which they are now transfusing, which is O negative blood. How would you approach now when you already have a control of common iliac artery on the right side?
It should be from the bony. The chances of bleeding from is from the bone, from the muscle, and the blood vessels. So if it is from the bone, I have to think of bony things like packing with the bone wax.
So you raised this question with your orthopedic colleague, and the orthopedic colleague said that this surgery he was performing for an advanced osteoarthritis, and he hasn't cut the bone yet. He had just dissected out, and he was about to open the capsule of the joint, but then the patient started bleeding.
Is this patient is bleeding from the muscles then?
We are not sure. You have packed, you have tried, but the whole area is red. How would you control the bleeding?
I'll just go ahead and do some flow seal, superficial thistle and all these things, kind of flow seal and all these things.
Before calling this, orthopedic surgeon has already done all these things, but he was unable to find out the source of bleeding. You yourself did that. You packed it and then remove the pack. The whole area is getting soaked with the bright red blood. And more importantly, the blood is getting more thinner and thinner as well. As you have already mentioned, that patient is going DIC.
This patient has got a DIC then. So this patient has got a DIC. If it is not getting controlled with all these things, this patient has got DIC. And we have to go ahead and do a fresh frozen plasma. Transfuse bloods, fresh frozen plasma, 1:1:1. Check the platelets, check the fibrinogen. If the fibrinogen is less than 1.5, just go ahead and give fibrinogen. If the platelet is less than 100, go and do the give platelets, at least bring the platelets up to 100.
Will you do all these drill on the operating table, or where would you shift this patient then? Or is it a right time to transfer the patient?
Until the patient is stopped bleeding, I won't shift the patient out of the theater, because if we need anything more, this patient can be tackled under anesthesia rather than bringing the patient to the ITU. I'll still do the things on table rather than until the bleeding is controlled. I won't shift the patient out of the theater.
So the anesthetist is saying that these blood products and that result of TAG scan will need another 35 minutes. And the orthopedic surgeon is very much concerned that if the bleeding is not getting controlled, even the internal iliac has been taken controlled, but still the patient is bleeding. Any other option you are thinking?
Oh, I did not think of any other option.
Okay, time out. So
what were you there? What was there?
Okay. Okay. First, because I have put this scenario, I must told the source from where I got it. So the source is one of my colleagues who sat in his part 2 exam, and he threw this scenario to me. And he said that the similar kind of scenario came to me, and you are a general surgeon on call. How would you approach? He gave me his approach.
It happened to us 3-4 months back. One of my consultants literally had this and went to the operating theater. Literally, I mean, and so basically, I mean, tell me if I'm wrong, but one is you do, apart from say getting control, external doesn't work, internal doesn't work, or common iliac doesn't work. One is pelvic packing itself, and you have to go for the aorta cross clamp if you need.
Yes, that was the answer. That was the answer. That was the answer which I wanted you to go.
So you need to go for the aorta cross clamp. And aorta cross clamp.
You reached up to a one level, and then you progress it to another level. But its other level was, I will do a cochlearization, I will do a kettle brush maneuver, and I will take either an aorta control in the intraconcolic compartment, or I will take a supraceliac aorta control.
Is it that like can it happen like this?
Yes. Yeah. We had to tie off the internal iliac. Couldn't do anything else. After an aortic cross clamp, we found that the internal iliac was damaged. It was like a branch of it had, kind of dissected, gone up to the internal iliac and bled from there. And we tried suturing it, but the suturing was such that it literally shut it off completely.
I don't want to go and clamp the aorta, isn't it?
No, but aorta cross clamp is the answer for damage control.
See, this is the answer. That's where I wanted you to go. That's where I wanted you to go.
That's the solution. It's damage control.
So you were right in packing. You were right in unpacking and trying to see whether the perforators are not, or you can find the bleeding perforators or not. If not, then your next approach was very good. I will supine the patient, take a control of external iliac artery. If that is not, then there are some branches of internal iliac artery that also supplies. Your approach was that approach was also very good. I will take the right iliac artery control. That was fine. That was fine, very fine. But the next approach is that I need to do a laparotomy, and which means that I will do a kettle brush maneuver, and I will try either take an infracolic compartment, but I would prefer that I will take a supraceliac control and cross clamp the aorta, because then you can only.
I was just like, is it that severe? Is the question? Okay, yeah.
Sorry, I don't know where it is.
Good drill.
Don't worry.
No, if it comes, these are the things which is going to, like, you will get the same scenario. It's not like you won't get the things. You will get the same scenario.
Yeah.
So shall I tell you my observation?
Yeah. Just I was waiting for it.
Okay. No. So the first thing is that I think your initial approach in this case, I wouldn't agree with. In terms of, he's given you it's a 5-minute clinical scenario, first of all, not case. And he's given you a very clear-cut scenario of they have been bleeding for some time. The orthopedician has done everything possible. The anesthetist is running for blood. So I wouldn't, in this case, start from the beginning and say, I will, I will send the blood for cross match. Your role is come here as a specialist to try and sort the bleeding. So how I would approach it is, I would say my main concern is whether the bleeding is in a local area near the hip, or potentially if this bleeder is in an inaccessible area, either retroperitoneal, or assuming, thinking in mind that, so that way you play both cards. I know you were saying like if it is local, you'll pack, you'll check, do all the things. So, but your thought process will be, what if it's not working? Because clearly this scenario is going to take you somewhere which you're going to be involved in. So I wouldn't say do the things like, I mean, I would assume it is obvious that, say, blood loss is being checked, blood pressure is being checked, anesthetist is running for the blood. So you need not say, in the capacity of a general surgeon in this scenario, say, I will organize blood, I will check, you know, I, you can raise the concern. You can raise the concern that I assume blood is being prepared simultaneously. I will ask the anesthetist what the situation is, or you can check the blood pressure in terms of whether you need to do damage control right now or whether you have the chance to go and explore. But don't waste time. I wouldn't waste time going into all these details again. So I think I will cut straight to the chase and say I will try and assess the point of bleeding. I will take a quick look to see whether it is locally in the wound or area. And like you said, yes, if it is obviously, because if it is DIC or oozing, I don't think the orthopedician will be calling you to theater. So it is usually a scenario where there is arterial bleeding. So I would jump to the chase. That is my first observation. And yes, the second thing is, obviously, in the exam, if you come to a point of saying, I don't know, I don't have a clue what to do next, before that point, stop and say, I will call for help. I will either see
I should have said that. Yeah, I was a bit,
because what happens is, again, with us, with Indian exams and everything, we generally trend to what is the cause, when we write. It doesn't matter in this exam what the cause is. It just matters what is your next step. So I think before even, it's a good thing that this happened now, so that in the exam, if at all you come to a situation of saying, I don't know what's going on, but you have to say it in that manner of, at this point of time, unfortunately, I'm not able to control the situation. I will discuss it with my orthopedic colleague and the consultant, and I will try and see if I can get help with a senior colleague, with a senior surgeon or a vascular specialist.
I should have called the vascular people, I think.
Exactly. So this is more important than, even if you know, and even if you get to the point of next time saying aortic cross clamp, I would still say I would be on I would try to find out who the vascular surgeon is on call if they're available. Then the examiner might say, no, they're not there, or they're 30 minutes away. The scenario will change, but you'll score marks. Score marks because you said vascular surgeon has to come. And so those are the important things, I think, in this scenario that are getting missed out, because you're worried about what the cause is, and you've done some steps. That's fine. It's completely okay if you're not able to go to the next step. But before that, you'd need to say, I will call for help. And, whatever. You can say, I will reassess the situation. I will think about this from, okay, so you've told me that. So the way you say it in the exam is, okay, so you've told me so far that the orthopedician is not concerned about the bone. You said he's not able to, he's not cut through it, he said. So, okay, I'm going to rule out that as a cause. I'm going to still continue to think that this is potentially a major vessel, because you've told me that there is spurting, there is bright red blood. So I'm thinking that this is still arterial. So so far I've not been able to control it. And then, yes, if you get the idea that you can get proximal control, it's fine. But even if you don't get it, at least you're pulling through till the time gets over, and you're making up the space. So I think those are the things.
Yeah, I think as well. I mean, I completely agree. I can't agree more than that. More than this, which Senthil has expressed, because in such scenario, you already have one primary surgeon there. You have a primary anesthetist, and there is a big team available. So you should not be much worried for their part, their job. And you've been asked to give your expertise, your skills, your
so basically here we have to approach it in a way that how far you are going to proximally control the
even these tag scan, FFPs, platelets, they were also to me for useless, because I believe that
data scenario, it's not your responsibility at all.
Because this whole situation was chaotic and everybody was running there, and I mean, sure. I mean, if anesthetist was a junior, he or she might have called their expert as well. I
Mm.
mean, a person might be an intensivist, might be there as well. So they might
Yeah.
be taking care of the patient more good as what you think being a surgeon. You have been called to deliver your expertise, your skills, and that should be
Yeah.
only be on that part, which
Like,
is
so I
locate
think,
the blood.
yeah, just concentrate on your part. Like, even the things like you said, even the second time you said, oh, it may be DIC, I will give vitamin, I mean, I will give FFP. I don't think in this scenario those are relevant, because your anesthetist is probably already given FFP, arranged whatever, how many ever units blood, etc.
Yeah,
So
Yeah.
and I think that
relevance is only what you are able to do.
So, what, Sakib, if I would have said this next step of cross clamping, how will this scenario proceed further?
I believe that this will come as a last bit, because you have controlled the main delivering vessel, right? Main center, you have control, you have taken a control, and there will be a minimum chance. At this point, the examiner has to say that the bleeding has stopped, because there is no other option.
No, the thing is,
Yeah, or he may
if
say,
it is
no, I'll
if it
tell
is
you where the
a common
scenario will go.
iliac artery, if it is a common iliac artery, if you control the common iliac artery, is there any possibility of bleeding still?
Yeah, because
So the thing is, Varun, it's much more difficult to control the common iliac than put aortic cross clamp, in my opinion. For a quick damage control, if it is external iliac, it's fine, because even if you lose it, it is fine.
so so
Uh,
so so the other thing is that
yeah,
you ignored this part that I was giving you a right clue that
Mm.
this structure are on the hip, which is the junction of a torso and the lower extremity. It is not supplied by only this external iliac artery. From the posterior lateral abdominal wall, your main abdominal vasculature, your all these vessels also make go and join there and give their collateral supplies. Buttocks muscles are supplied by entirely different subset of vessels. So are the anterior part of the hip joint is supplied by different vessels. So if you are unable to control, it means that either a missed injury or
Some
or
anomalies or whatever.
yeah,
Some
no,
whatever.
no, Varun. So
whatever.
I think what Varun's asking is, if suppose say in within 2 minutes you had come to this situation of I will do an aortic cross clamp, your thing is, what is the examiner going to ask you next?
No, no,
Yes, exactly.
So
I think that then you have jumped it. The best way is
no, no,
that
no, 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 no. You could have come to it on time, but your next scenarios, I'll tell you, is either one, he will say, now there is an injury in this vessel. You know, there's a 1 centimeter. You can now see the site of bleeding. So it will either go to a situation of will you suture, will you repair, will you ligate, or
Okay,
it
okay,
will
okay.
go to a scenario of he'll say, okay, now the patient is stable. Tell me about damage control surgery. Now the
yeah,
patient is stable. Define damage control surgery.
damage
So
control
they will
surgery in
always
terms of
have.
in relation to the vascular damage control vascular
Yeah, yeah,
surgery.
yeah, yeah.
Yeah,
Or it could even be now this is patient is stable. What grade of shock was this? Or what are the stages of shock, or what are the
Mm.
stages of
It can
hemorrhage?
go to some other yeah,
yeah,
line.
Exactly. So it will switch there once you answer usually if they're leading you into a scenario and you've
So
answered the correct
the crux
question,
of
it
the
will go on to
scenario
the next.
is go proximal as much as possible until the bleeding stops.
yeah. That's what I wanted you to take go. That's where I wanted you to go.
That's it.
I'm sure about that. This regimen, this maneuver works for this maneuver is applicable for any
Yeah.
below the diaphragmatic hiatus, right? I'm not
Yeah.
sure
Yes,
what.
and
No,
it can be
it's
both
not even
arterial plus
below. It's
venous.
even for aortic cross clamp in the thorax. It
Yeah,
ends
yeah.
in
No,
it ends
and
in the
both
thorax as
aortic
well.
plus venous. It works for both aortic plus venous naturally.
Yeah,
Yeah.
yeah. But and I think this is a scenario which, I mean, from now onwards, whenever the patient is bleeding, either from a pelvic surgery, gynecological surgery, it is applicable to everywhere. Sarcoma surgeries in the lower pelvis, gynecological surgery, urological surgeries, difficult prostatectomies. If they
Yeah.
are
Yeah.
bleeding, the scenario should always run. I will pack, I will assess this local area, I will stay cool, calm, and I will explore proximally. Proximally, take to the external iliac, then internal iliac, common iliac, and then the main aorta. Aorta can be
Yeah.
approached through the infracolic approach or the supracolic approach. Supracolic is the supraceliac control of the aorta. Yeah.
I
All
think
right.
someone, Noor, rightly asked the question of what is the role of IR over here.
Emergency, I don't think emergencies, they don't.
Yeah, so I think IR for controlling bleeding is if the patient does stabilize to a certain extent. You will not be rushing a patient who's bleeding actively in theater to an IR suite. If you pack and if they say now something is stabilized, and in this case, the only role for IR I know is the potential role that I've experienced is IR can come to theater and they can balloon and occlude the vessel.
Yeah. So,
Instead of you doing the aortic cross clamp, the IR can come and occlude, say, the aortic, or if you think it's right iliac, common iliac, or external accordingly. That may be the only involvement of IR in this situation if
So
it comes to it.
options for aortic cross clamp is, one is aortic cross clamp passage, or we can do a balloon occlusion.
so this,
Exactly.
this this balloon that you're talking about is called a Ribova catheter. Revascularized endovascular aortic balloon injury. I'm not sure what is the full form, but Ribova is the name of that catheter.
Ribova catheter. Okay, all right.
REB. I can Google it. Ribova catheter full form. But it includes all these things. What we are saying that
Nice
uh,
drill.
it is called Ribova catheter. Ribova is resuscitative endovascular balloon occlusion of aorta.
Is this the catheter which is used for the SMV occlusion and all these things as well?
No. This is only for the bleeding vessel. In the traumatic setting, what you do is either femorals, you take approach and by looking at the image, fluoroscopic images, you go beyond the supraceliac level and then you inflate the balloon, which is resuscitative endovascular balloon occlusion for the aorta, and you occlude the aorta. So then for a time being, you don't have an influx of the blood coming proximally from the chest, and then you see your sites if you can find out the injury, and then you repair it.
All right. Okay. Nice. Shall we go to the next?
Yes.
Sendil, do you have any scenarios like this? Like Sakib, what Sakib said?
Always create scenarios.
Yeah, it's a fun, until you get into the right thing.
No. When you actually went to the internal iliac and common iliac, I thought that you will also go proximally. I don't know why did you stop, but I
No, the
thought that now
problem
he
is
has
the
at that
problem
point
is I thought of
now
I thought,
he
how
has
much is
on the
a
back on track.
brain? Anyhow.
Yeah.
But the take home message is that this is approach for all kind of gynecological prostatectomy,
Yeah, that's it. Like
sarcomas.
the control, the
Yeah,
crux of the scenario is go as much proximal as possible and
agree.
control until the bleeding stops. That's
Yeah.
it.
Or call for help.
Yeah, I'll call for it. That's more important. Talk to the vascular team.
Most important. Because, see, the thing is, you never, like I said, when they examine in each scenario, they already have like 10 points which are answers. If that happens to be one of the scenarios that is meant to lead you to the answer of call for help, because either you say, you're general surgeon and like you asked Saqib, suddenly there's a biliary injury, etc. That will probably be scored as yes, I will check with the vascular surgeon, or I'll check with the transplant surgeon. That will be one tick off for them. So
Mm.
so they have their preset answers. They are not marking you based on what you answer. They are seeing if they have those things on their list. Have you, whenever you come across one, they just tick off. That's what they do in MRCS, FRCS, both, as far as I've heard. The way they
No, I
mark
heard the
about.
FRCS, they don't have any set answers, Sindhil. I
No,
heard
no,
that
no,
there's,
no. They have. Is it? At
yeah,
least earlier
that
they have.
that is
I
what
don't know if something's
I
changed.
was said. Like they don't have set answers, but they have things which not to be said. If you
Of
say
course,
something, yeah,
both
that
they
that
have.
will be there. That should not be said. That's what I heard. So.
Yeah. No, no. I think both are there. They very much have a set of answers. Is what I've heard
Hmm.
from the examiners.
All right. Okay. Let's go to the next scenario.
Yeah.
I want to go ahead again.
Do you have any scenario with you? Then I can, instead of you asking, I can ask you.
Varun, you have made a one
Same thing
scenario,
according.
so you can give it to Santel if you want.
Yeah.
I've got scenario. The thing is, but it is not like just a second.
No, otherwise, I can. Give you.
Because I have practiced one, you have practiced one, and
Yeah,
if you
I've
give a
got
practice,
another emergency scenario like the same, but yeah, I've got the scenario. Yeah,
Do you want to share the screen and I'll ask you
yeah.
those questions
It
and I'll
starts
add
from the
on.
question. It starts from the question. I'll just go ahead and. Do you want to do it?
No, no, no. I'll question you.
No, I just had a one CT scan. I don't have anything about
Okay, okay.
CT scan
No, that's
report.
fine.
You
I
go ahead
can
and
I can
ask
give you a
something.
scenario.
I'll be the candidate, and then we can discuss.
Sure. Right. Yeah, give me 20 seconds to formulate this. Everyone can take a water break. Ah, got my board and marker. Oh, I've been up since 5:30 this morning, so my GCS is slowly dropping. It doesn't help watching the Champions League final on Saturday in the pub also.
What I feel is like ideally we have to touch all the emergency scenarios in
Yeah,
the
yeah,
tracking FRCS.
definitely.
no, I guess this is a good theme that we have picked up, and we should continue with the emergency scenarios for next at least 15-20 days. And
we have got
Okay.
plenty of things to cover.
No, we can cover it. We can cover it because you know that in emergency scenario, generally you can go to the HPV as well. You can go to the vascular as well. You can go to the colorectal as well. This is a good part of the emergency. Like the scenario that you gave me, was thinking that you may not give me you may not ask me an indication for a liver transplant in acute fulminant liver failure after a trauma. What is the role of liver transplant? I was thinking that you may not ask this question. The thing is that the emergency, if you discuss emergency scenarios, you can go either way and you can cover everything more or less.
Everything, yeah.
So
Okay.
I think
Right.
give a good time, give a good plenty of time to emergency scenario.
Okay, Varun. So you're on call and it's about 1 hour to go for your shift to change, and you hand over um, your you're the consultant on call and you're handing over. Now there's your registrar calls you up with information that there's a patient in A&E, a 50-year-old female, and he says that the abdomen, they've called him because of hypotension, and his abdominal findings are that there is generalized tenderness in the abdomen, and he says he wants you to come and have a look. So how will you approach?
This is a 50-year-old female with a generalized abdominal tenderness and hypotension. On the way to the A&E, I will think of some kind of acute abdomen in terms of either bowel perforation or in terms of bowel obstruction. Thinking this in my mind, I will get more information from my registrar regarding the history and examination finding. Focusing on the history, any abdominal pain in terms of Socrates, associated features like vomiting, bowels, opening of bowels, temperature, and coming on to the history, what are the medical comorbids, previous surgical history.
Right. The registrar says the emergency consultant who is reviewing us as a BP is 60 systolic, and he wants to know if you want to give any blood.
So if this is the scenario, I'll on the way to the A&E, I'll check whether this patient is being managed as per the CRIS protocol, resuscitating. If the blood hypotension, is there any bleeding or anything which is happening. Any cause for the hypotension has to be checked in. Is it the generalized abdominal pain and the sepsis causing hypotension, or some bleeding causing hypotension? If it is so, I'll
So you've
go ahead.
reached the A&E. They're rushing fluids. They've given a bolus of 1 liter, and the BP is 80 systolic. What else do you want to know about the patient?
I would like to run the sepsis 6 protocol, and on the basis of CRISP, give check whether this patient has got IV fluids, oxygen, and catheter, cannula, Vibo cannulas, catheters, sepsis 6.
Right. So they followed sepsis 6 protocol. They've done what you mentioned. They've also started antibiotics, and they've sent blood cultures as well. So how would you like to proceed now?
So this patient is in profound septic, is in septic. What about the history? Is there any examination finding which is suggestive of anything like?
History is she came in with history of severe abdominal pain since this afternoon. So it's about 4 hours history of abdominal pain, and then when the ambulance went to see her, the blood pressure was very low. She was cold, clammy, and she came to. Then they brought her to the A&E. They're not sure of any other history as such.
Any fast scan which has been done? Any previous?
There's no history of trauma. They're quite sure there's no
history. Allergies, medical history, previous.
No allergies, medical history. There's no significant comorbidities.
I will rush the fluid, and this patient, on top of my mind now, this patient may need a laparotomy, damage control laparotomy. I don't think this patient, if the patient is fit enough to get the CT scan done, if the BP is falling, I don't think this patient is fit enough to get a CT scan done. Have a quick examination of the abdomen. Is the abdomen is peritonetic or not? Is this patient is bleeding anywhere? Is this patient has got ruptured aortic aneurysm? Check is this patient has got any reason for hypotension in terms of sepsis or in terms of hypovolemia.
So the emergency consultant said before you came in, their team they ran a scan and to rule out AAA. So they've ruled that out.
Okay, so if it is a AAA which is ruled out, any lactate? What is the lactate?
Yeah, the lactates were 6, and with fluids they came down to about 4.5. They've only given 1 liter of fluid so far, and so like I said, the consultant was asking whether you want to give blood or what is your next step, whether you want to give more fluids.
I would give more fluids rather than blood, because if there is no aortic aneurysm, this patient might be it's a sudden onset, isn't it?
Right. So another liter of fluids goes in, and yes, it's all sudden onset. Another liter of fluids goes in. The blood pressure comes to about 90 systolic, and still tachycardia about 130.
If the blood pressure has come up and if the tachycardia is there, I will get a CT scan done. If it is a partially responding patient, partially responding to the fluids, if the patient is stabilized, if the patient is conscious, if the patient is transferable to get a CT done, I'll get a CT done. If not, I would like to inform the theater to go ahead and prepare for the emergency laparotomy and consent the patient for laparotomy in terms of damage control surgery. Make sure that this patient enters the theater, WHO checklist done, laparotomy done. Is there any check for quadrants? Is there any spillage or anything? And check for the integrity of the bowel. Is there any perforation which has caused this sepsis?
Right. So you decided to take this patient to theater, and patient has been anesthetized. Anesthetist says she's quite poor with the induction. The blood pressure dropped, but they're giving fluids, manageable. And you're doing the WHO checklist. You're just about to open up the patient, or you start your incision, and your junior colleague from the team comes and he reports the amylase levels are about 850.
Oh, this could be a pancreatitis, and I won't operate on this patient if the patient says amylase of 850.
You've just opened the abdomen.
If I open the abdomen, I just keep a drain and come out. I don't want to proceed with anything because nothing wrong in opening the abdomen until and if you are not sure that this patient is not picking up the blood pressure. Just have a look at it. If the patient doesn't have anything else apart from perforation or everything, it can be negative laparotomy. Nothing wrong, but keep a drain and close the abdomen. Make sure that this patient is transferred to the ITU and manage this patient as an acute pancreatitis and take it forward from there.
Varun, the junior resident also tells that the SHO also tells that I have seen the records and the patient was advised cholecystectomy as well for the gallstones. And you are still in the middle of the laparatomy.
The informations are so...
Huh?
The thing is, if the patient had a cholecystectomy...
No, the patient was advised. He's on the waiting list.
Saqib, sub-scenario is you've opened the abdomen, now you know it's pancreatitis. And he also mentions that there are gallstones. Or even you find.
No, I won't proceed with anything. I'll just keep a drain and come out.
No, patient was on waiting list for a cholecystectomy. That's what I'm saying.
No. I won't do anything.
But
I won't do anything.
So you would do post-op lap cholecystectomy, which will be a very difficult task.
No. Like.
So when would you plan the cholecystectomy then?
If the patient is
So the thing is that the SHO has given information that the amylase level is 850, and he also he's a clever SHO, to be honest. He is the most clever SHO, and he has also given you his idea that he thinks that it's likely a biliary pancreatitis, and patient was on the waiting list for cholecystectomy. What would you do next?
Ideally, the patient should. We should not operate on a patient with pancreatitis. Having been opened the abdomen, if there is nothing wrong in taking out the gallbladder if the patient, but post-operatively, I would like to do a check whether this patient has got a CBD stone. Check the CBD as well, whether the patient has got any stones or anything. But I won't explore any CBD, but just cholecystectomy is okay, but I won't do it until the pancreatitis settles down. I'll do it as an elective setting rather than after the laparotomy.
Would you do a laparoscopic approach or open cholecystectomy?
Laparoscopic. Post-laparotomy.
Post-pancreatitis, post-laparotomy.
Post-pancreatitis, I don't want to disturb this patient. I don't want to do a cholecystectomy because this patient might have not been consented for cholecystectomy, first thing. Second thing is with acute pancreatitis going on, I don't want to involve the gallbladder. Oh, come on, guys. Things are still...
I am not doing anything. Saqib has hijacked my scenario.
Yeah.
No, when the SHO came in, so
I thought I get excited when the gallstones are there. Saqib's also getting excited of gallstones.
When the SHO came in, so I thought that let's give one more thing. Yeah.
One more thing. Oh,
that was coming in the post-operative period, depending upon Varun says. Like he said, we'll close and put a drain. So I was going to say next day LFTs are up. But anyway,
if the next day LFTs are up, I will just go and do a MRCP and ERCP, get these stones out, and then put a stent or not.
All depends. If that patient's in ITU with multi-organ dysfunction, you need to do anything at that point.
Varun, on a serious note, a comment where in the whole scenario, the mesenteric ischemia never came in, neither on a history, nor examination, nor on even investigation.
No, that is what I was a bit worried. Like I just checked with the Sendil. He said examination wise is fine. Examination is fine.
Yeah, out of
No, I didn't
proportion
say
pain.
examination is fine. I didn't go to examination at all.
The
You
patient
said,
was hemodynamic unstable. I mean, I was very carefully listening your history. You took all the history of previous operations, family problems, but you never took a history of cardiovascular diseases.
Mesenteric ischemia comes when the patient has got atrial fibrillation or any kind of comorbids. He said he didn't say any comorbids at all, I think.
yeah, I said no comorbidities, but I didn't
Yeah.
say anything about examination findings.
Yeah, but then
Anyway,
in examination,
shall we just go back to the steps of this and go through it, and then we can
Yeah.
points that.
Yeah.
Okay.
So my
first thing I
criticism,
think,
let me start my
okay.
criticism, Senthil.
Yes.
My criticism will only start, I mean, this was a very, I mean, in the start, the way the Senthil presented the scenario, I was thinking mesenteric ischemia. I wanted you to...
Even I felt the same thing.
I wanted, let me complete my feedback. I wanted you to take a history of, because I have written these points. So I wanted you to take the history of cardiovascular diseases. So as well, I wanted you to examine in terms of the rate, in terms of rhythms, ECG, cardiovascular examination assessment, and CT scan. When we were talking about this, lactate was very high. It was very suspicious of ischemia. You didn't think about it. Out of preparation pain, I wanted you to say that it might be a mesenteric ischemia, and I wanted you to go there. And then I also, when we were discussing the investigation in terms of a AAA rupture, I wanted you to see if you can get a CT scan in order to find out an ischemia or the vascular occlusion. So these are the things that I mean, actually I wanted you to say. But at any point, mesenteric ischemia never came in the scenario.
The reason why I didn't think about mesenteric ischemia is, first thing is, no previous past medical history of any cardiac problem. First thing. Second thing is it is just 4 hours history. That's what I think Senthil said. 4 hours abdominal pain.
Yeah.
Isn't it?
That was more suggestive of ischemia, because if somebody had developed an arrhythmia, a new onset of arrhythmia, and have thrown a clot, it needs just 4 or 5 hours to develop the symptoms and come in an A&E with this horrific presentation. What else you need? That was more in terms of an ischemia.
Yeah.
Okay. I'll tell you the scenario that basically, yes, I was creating. I remember the steps when I asked you. So, Shakib, is there anything else? Sorry.
No, that's fine.
Okay. So Varun, you started off with saying on the way to A&E, you're asking the history of your registrar. That's fine. So then that's why I changed it to your registrar is telling you that the BP is 60 systolic. So obviously the first thing is, okay, now that you've got to A&E, you took quite a long time to get to the examination itself. Like, one is you should have started off with resuscitation, first asking me, because I already told you 60 systolic. So yes, then you start, even at 80 systolic initially when you're told, your first thing is, of course, resuscitation. Now, when you came, you said, I am concerned about, it's good that you mentioned what you're concerned about first, rather than saying going to history exam. But you said, I'm concerned about perforation and obstruction. Now so with peritonitis, he's told you generally, I wouldn't be concerned first about obstruction. I would be concerned about perforation. And then obviously, then the other thing is ischemia and then pancreatitis. So I was leading the scenario in terms of either mesenteric ischemia or pancreatitis. And also on that same point, at the time of the operation, even in ischemic bowel, like MLAs can go up to about 600, 700, 800. It is, I mean, if it's 2000 LFTs, our D range is different. So you are very well right to say this. Look, this patient was peritonitic, hypotensive, and needed a laparotomy. Even if the MLS was 800 and I could not do a CT scan and rule out ischemia, then I have to take up a laparotomy. So you're very well. So that can play out both ways. And we literally, I'm creating this from a patient we had. So it's very, it's possible, and that both is there. So I think the deficiency or lacunas was in the initial part itself, that you took very long to get to examination and it took very long to ask about lactates, and also the other vitals. Like I only mentioned blood pressure, but I would ask, is there, before you say, is it sepsis or not? I would say, what is the temperature? What is the pulse rate? So because
Mm.
that is the kind of scenario that you're expecting. As soon as you see, either you see the monitor or pulse rate, temperature, then if I say temperature, then you can say sepsis protocol. And then immediately you're going to see, if you're a consultant and you're coming down to A&E to see the patient, your registrar has told you this, that, he's told peritonitis, the first thing you will do is examine the patient.
Mm.
Don't be sitting there and asking, have they done this, have they done that, have they given fluid? You will go, as everything is going on simultaneously, you will examine the patient. Yes, history, if possible, in an acute setting, as much as you can. Sometimes we don't get a history. Sometimes you may get a history that she may say yes if she's conscious oriented. But at 60 systolic, you're not going to rely on that history. You're going to rely on your examination. If your examination is peritonitic and she's 60 systolic, then yes, you have to say, I have no choice. I can try and attempt further resuscitation as they've only given one fluid. But so again, even the fluids, when I mentioned, you straight away went to laparotomy rather than asking how much fluids is given, or is the patient adequately resuscitated, would be my first concern.
Mm.
So those are the things that I wrote down as we discussed this. So yeah, I guess if you in the initial stage itself say my differentials are peritonitis, ischemia, pancreatitis, then that covers a few things. Then of course AAA in a setting of a 50-year-old female, AAA would be very, very rare.
Very rare, yeah. That's
Very,
what I,
very rare.
that's what I didn't say.
50-year-old female, that too. Even an elderly female, okay. But here, generally, AAA is more than 70 male.
70,
whatever.
yeah.
Yeah. So these are the things. The only other things that potentially the next thing is, if it is perforation, then what type of perforation? Eventually, you're thinking of, if you're asking, say, in history, I would ask for, say, constipation, etc., or history of diverticulitis, or is there history of NSAIDs or any, ulcer-related disease to see if it's PU-perf. But otherwise, I was generally going in ischemia or pancreatitis direction. So to try and get, just the how you're going to go to it. And I feel when you said laparotomy, then you kind of jumped into laparotomy, go in, open, I'll see this, that. I would rather you say, at this point of time, it looks very difficult to conservatively manage this patient. I will discuss with the ITU team and see, because again, ITU team, I think, has to be involved even like on the way to the patient going to resuscitation. Also, ITU team is definitely involved, or the anesthetists. So I would say I would discuss with the anesthetists, because if this is pancreatitis, then ITU team, what are they going to do? They're going to, if fluids, what I wanted to ask you is, if fluids is not enough, next is vasopressors. So I would say, if adequately resuscitated at 90 systolic, you've given 2-3 liters fluids, whatever it is. Next thing is, can you maintain with inotrope? So if ITU is involved and you can stabilize the patient to a certain degree, you try and get it to CT scan. Then it depends on the scenario how it's changed.
So here, basically, I think I should have done this way. Like, once the patient is not happy to be, is not able to be resuscitated with fluids, I should have checked with the ITU to get the support from them to resuscitate the one organ failure.
Or you say, look, I'm going to wait for the bloods. Or have any bloods come? You can ask, have any bloods come at this point of time? 2 liters of fluids have gone. Is there any bloods? And then if I say, okay, all the bloods are normal, then you can make your decision. If I say lactate so much, I might say amylase normal. Or if I say, then at that point,
and get the blood reports itself, isn't it?
Exactly. That's also part of your diagnosis, rather than saying, okay, blood pressure's dropped straight to theta. So have the bloods come. You have to ask at that point of time, at least when you're thinking of theta, because your ITO also is going to ask you, what are the bloods, So those are the things. So I think those important, like crucial junctures where you have to say at this point, what have we done? What can we do more? What is the next step? Ideally, what would you like to do? And in this scenario, what are you forced to do? I think those are the things. Again, it comes down to approach. It's not that you can't manage a case of either peritonitis or pancreatitis. The approach and getting
how do we approach if the patient is not properly resuscitated? What are the next steps in the resuscitation? That's it.
Yes. I think it's about questioning. See, it's similar to, say, doing an audit and retrospectively seeing a case. Then you tend to think of, oh, how much fluids have they given? Have they given enough? Have they given inotropes? Did the patient go to ITU? What was the lactate? Did they repeat the lactate? All those things. So it's kind of, you're just questioning everything. And that's how it will be with the examiner as well.
Are we supposed to question for each and everything? Or are we supposed to say
No.
these steps continuously and they'll stop us to give the
I
answer?
think when you start, naturally they'll assess your flow. So when you start off, one person may start off and say just one sentence. I will do ATLS resuscitation protocol and stop. Then that is also not good. At the same time, if you constantly go on, I think they will stop you to try and guide you. So I mean, like you
Mm,
rightly asked, is there a history of trauma? So that's good. So you ask that, and you have to ask. It's natural that you're going to ask in this sitting. Is what is okay. So you've told me blood pressure is 80 systolic. May I also know, if there's any fever spikes, if the respiratory rate and tachycardia? Then they'll either summarize and say yes, there is some tachycardia. The patient looks to be in sepsis. They have done this and lead you on that path. In which case, it's probably peritonitis, whatever it is. So it's a
mm,
balance. It's a balance of saying a few things, giving your approach and ideas, and then letting them lead you.
mm. Nice,
So
nice. Thanks. I think it's this is how we have to think, like broad way, rather than just focusing on something like
Yeah.
lateral thinking.
Yeah.
yes, yes. I think it's also very much about how, I mean, you approach it the way you would actually clinically approach it. See, I feel for the sake of exam, you're trying to cover more points than you would in a clinical setting. If you are on call today and you go down to any, it's the same things you do there. You have to try and reproduce in the exam. It's just that the scenario is changing. Again, you don't
Mm.
need to concentrate
No,
on
that's the
what
thing. That like
the diagnosis is.
I just felt the same thing. As soon as I go, I'll just resuscitate the patient. Resuscitate the patient. If the patient is not resuscitated properly, ideally, what I used to do in this scenario is I'll put in a catheter, check the output. Is this output enough for the
Yeah, so that's a
resuscitation?
very good thing. So if you
So
if you say, what is the
that
urine
will be
output?
my first approach. Like you resuscitate, even the blood pressure is not picking up. Is this
Yeah,
patient pouring enough urine output? If this
yeah,
patient pouring enough urine output, then I'll do a CT scan straight away.
yeah.
Even if the lactate is high, I'm not bothered. Even if the urea
Yeah,
plate is
you're
high,
only bothered about if someone is stable enough to shift them to the CT scan. So
yeah.
even see, 80 systolic could be stable. If you discuss with the ITU team and they say, yeah, fine, we'll put her on inotropes, keep it at 90 systolic, we'll take her for a scan. That's what happened to us actually in this scenario with my patient. It was literally in the morning time. Initially, we gave fluids, resuscitated, BP came up temporarily. They started a very low dose inotrope. So then I called my consultant and I said, this is the thing. It looks like it's frank peritonitis. I said, I think this is potentially a candidate who may need theater. Are you happy to, proceed with either a scan if they say she's stable, or do you want to go to theater? And then he said, we'll do the CT scan, actually, again, early morning and handover time. But then literally after that, after about half an hour, then the ITU team said, look, the inotrope pressure has really gone high. They were literally thinking of going CT and then theater, but then they couldn't take to CT and then went straight to theater. And so it just depends on, literally how you're going to approach there, and what is, if the scenario changes, then just backtrack and say, okay, now I need to think about this, because sometimes you may answer and then you may find that the examiner is leading you in another way. So you have to,
Mm.
so like you said, when I said that aprotomy, its amylase is 850, you still need to give both. So you need to say, oh, at this point of time, I would like to retrace my steps. I will take a pause and just consider that this possibly could be pancreatitis. But I may also, considering my clinical judgment of the patient before with hypotension, and now that she is on theater, I will also confirm that she doesn't have any ischemia.
Mm.
So that would be ideal. So it's just that you have to lay out both scenarios yourself and answer it. Then the examiner ticked his box without him asking you, oh, but even though amylase is 800, you see some, ischemic bowel or congested bowel or whatever.
No,
Okay, so
usually, ideally, when the patient is anesthetized for laparotomy, it is better to go ahead and do a laparotomy and check what exactly is happening. Even if it is pancreatitis, doesn't bother.
exactly.
We,
So
we,
you're very
we have
well
clinically
welcome
made a
to say
decision to
either.
proceed. That's it.
Yeah,
Clinically made a
because
decision to proceed. That's it.
exactly. So you can back up your clinical decision to proceed and say, yes, I will take into account that the bloods have come and the amylase is so much, but my
Mm.
indication to take a patient up for laparotomy has not changed. And now that I am on the table, I will explore the abdomen. And yes, if I do find it is pancreatitis, and unfortunately, I will only, put drains and close the abdomen, but I will also assess, rule out ischemic bowel, rule out that there is no obvious contamination.
Other pathology. Saki, we were
Perforation,
talking about removing the gallbladder. What is the thought process here? Like, ideally, if with the pancreatitis, without a consent for cholecystectomy, I won't do anything. I'll just come back, even if the post-operative, the LFTs are getting rearranged, rather go ahead and settle the pancreatitis and then do the gallbladder surgery.
I read only in MCQs when we were preparing for that if you have opened an abdomen in an elective in an emergency patient, but the patients is hemodynamically absolutely stable, then you can think of doing.
This patient is an absolutely unstable patient.
Then no role.
No, but that is what I'm saying. We are taking this patient to theater.
There is no role.
As this patient is unstable. So in that scenario, I won't touch this gallbladder, and also considering the consent, I won't touch the gallbladder.
Don't touch unless.
Yeah. No, fair enough. I mean, if you're going to technically analyze it, what I would say is, see, exploratory laparotomy, when you do it, of course, there are certain things, even if you're not consented for, that you can go ahead for. I mean, you may consent for appendicectomy and you go in and you find a necrotic gallbladder. It is not right to say close and
yeah, that is something different. That is something different scenario. But here the indication is something different, isn't it?
Yes, I would say I think your question should be, I think it's quite fair to say if it's unstable, you don't remove anything. Your question should be, if the patient is stable, what would you do? So one scenario can be, of course, you've got an inflammation patient has gallstones, and it's obvious. Two is, you palpate the gallbladder. If there are stones, then it's different. Because here you don't know what the cause of pancreatitis is. You're assuming it is due to stones. But I would say your concern for, say, the CBD stones, etc. So you have gone into the concern of post-cholecystectomy complications. But your concern is presently, one, whether you have confirmed the etiology of pancreatitis. Patient may have stones and the patient may have drunk alcohol last night, whatever, how many units. So you can't, so you're jumping the gun in saying what will happen if there are CBD stones. So first, I think I would say, I would like to confirm further at this point, if the patient is stable, that if there is any imaging prior to this which suggests gallstone disease, can I rule out other causes of pancreatitis if I can? So then suppose the scenario examiner says, yes, there's no other cause of pancreatitis. It's unlikely you're going to go into such a detailed scenario, but yes. The second thing is, you can see the LFTs. If the LFTs are normal, it is unlikely biliary pancreatitis if LFTs are normal. So you will have transaminitis. So I will say, I would diagnose biliary pancreatitis with the fact that the LFTs show some amount of transaminitis. And if the LFTs are normal, then you can say that potentially then you're not worried about CBD complications if you do a gallbladder. But you'll have to.
But the thing is, having entered the abdomen, when the patient is stable, the one valid point is, we are not sure whether it is biliary pancreatitis or pancreatitis because of anything, even though you see a stone in the gallbladder. So it is better to not to touch the gallbladder until we know the reason for the pancreatitis, and put a drain and come out, and then assess the reason for we know there is no need for any ultrasound post-operatively. If the patient's LFTs are getting deranged, then think of MRCP. Is MRCP in this scenario will be good, or straight away ERCP is better? Because we have
again, the first thing is how stable the patient is. If it is severe acute pancreatitis with MODS and MODS and no cholangitis, there is no role for MRCP or ERCP. You only have to manage the LFTs, monitor the LFTs, and see the trend. You may have a stone in the bile duct or not, or it's passed or not. The only indication for urgent ERCP and MRCP there is cholangitis. You may do an MRCP to evaluate usually when the patient is stable.
Okay. If the patient is in MODS, then nothing. Just stabilize the patient.
Then it is only critical care.
Okay. If the patient has got cholangitis but not in any hypotension or anything, then go ahead and do
cholangitis. When you say, it is usually a picture of septic shock with the mods with the acute pancreatitis. Then you
Mm-hmm.
consider an urgent ERCP.
Okay. So
As you
urgent
control the
ERCP, not
source of
MRCP,
sepsis.
isn't it? That's the question. There's no role for MRCP. Here it's ERCP.
Yeah, I mean, if it's severe cholangitis, then it is ideally
ERCP.
ERCP. That's all,
ERCP.
syncrotomy and done. There
All
shouldn't
right.
be a role for MRCP there.
Yeah. Okay.
Yeah, MRCP usually is only if patient is stable, then you're considering whether either you have expertise to do lab chole CBD exploration, in which case you may or may not want the MRCP. If you're considering it as stones, you're considering how much value your ultrasound has given you. If it says biliary dilatation, if the ultrasound has picked up a stone in the CBD, again, there's no role. May not
For
need.
MRCP, yeah.
So then you're only considering if, say, the LFTs are deranged, this patient is now stable, you're considering going in for a lab chole for biliary pancreatitis within 48 hours, 72 hours, same admission. But you're worried
Is it
about the
is it
deranged
is it
LFTs.
is there any time frame, or is it in the same admission? That's what the NICE guideline says, isn't it? NICE guideline says
Same
immediately
admission,
in the
ideally
same
within 2
admission.
weeks.
We are
Same admission or ideally within 2 weeks.
ideally within 2 weeks. Oh yeah.
Yeah, that can
If the
change.
patient has
Trust
got
policy,
any,
it can change.
if the patient has got any organ dysfunction after 1 month, isn't it? 1 month after the
I don't know if there's a timing after organ dysfunction. It depends on how the patient is. It depends on one, if they've recovered from their pancreatitis episode. Two, if there is any collections that are in the pancreatic head and gallbladder area that could potentially, say, come into the field of your surgery, then you would still delay it. There is no role. If the patient has severe acute pancreatitis, even if it's biliary, you can still do the gallbladder later on, even
okay.
if it's 3 months, 6 months.
No, I think I read somewhere about the once the organ failure has settled, then it after the organ failure settles, it's 1 month after the organ failure settles. I think
Okay. I've not read that.
guidelines. I think I did an audit on this thing, biliary
Okay.
pancreatitis. So
Okay.
in that audit, I think I read about this.
Okay, I'm not aware about
But
the
you are
timing.
right. One thing is you are right. Do a gallbladder surgery on the same admission or within 2 weeks.
Yeah.
And if there is an organ dysfunction, then it is 1 month after the thing settles down.
Okay.
That's what I remember, but I'll have a look at it.
So that's the thing. 1 month after the thing settles down is that mods itself takes 4 weeks with its necrosis and stuff to settle down, and then 1 month after that is. From what I've learned and read, it is basically the patient has to stabilize, get discharged, and then only you reassess depending upon how much collection is there. There's no timing. I mean, some patient may be ready in 6 weeks, some patient may be ready in 12 weeks. But it's generally until the patient stabilizes, you don't do the lab code.
Okay. Nice discussion, isn't it?
Yeah, it was good. Shall we close the session?
Yeah. Shall we? When shall we meet next?
When we are meeting? When are we meeting again?
I don't know. You have to say.
Maybe Wednesday, if it's right for everyone.
Yeah, that's fine. I'm off this week. I've got weekend night, so I'm off this week. I'm okay with any day, time.
Yeah, so we can collect some more cases and then come on Wednesday, or maybe I can try to make few emergency cases, but we'll stick with the emergency cases for now, right?
Yeah, thank you. Yeah, sure.
Okay.
So now that now that
you are saying about this patient after laparoscopy, what happened?
So one patient I had was taken up. That was not. I came at night with for after handover. The patient was on table. Similar 56-year-old lady. She had abdo pain and collapsed, and so they took her to theater. They literally. I just came into theater. They had opened the abdomen or started opening, and I quietly asked the SHO what is the amount. Amynase is 700 and something, he said loudly. And then my colleague, the registrar with the consultant over there, both of them were like, Amynase 770. I thought it was 70. Basically ended up exploring acute pancreatitis. Worst part is by the time that thing came, they had explored like top to bottom. They had seen, or they had seen some, that calcification and stuff in the lesser sac, but they thought it's a DU perf. Then they started mobilizing the duodenum.
Oh my God.
And so anyway, that patient survived, went home. We tried to do her gallbladder like I think almost 4 months after the op. We
Anyhow,
tried to do the
so
gallbladder and abandoned the operation.
we didn't approach in a different way. We approached it the same way.
Yeah. So, but the thing is that there again, the discussion in like the meeting and all that morbidity meeting, mortality meeting, not mortality, but the meeting, is that see the amylase of 600. Yes, you have to keep clinical suspicion that it may be pancreatitis, but you are still okay to explore the patient who has collapsed.
This is
has hypotension.
basically we have to open the abdomen if the patient is clinically unstable. Doesn't matter whether this patient has got a pancreatitis or any other pathology.
But again, the critical point there is, has the patient been adequately resuscitated?
Yeah.
So that is the thing, because here what happened in this scenario was basically that the surgical team had seen this patient at 2 p.m. and they had said, blood, CT scan, everything. At 5 o'clock, they got a call saying, the emergency department called saying the patient collapsed. That basically was, just like she kind of collapsed, not like she crashed. She just, had one episode of hypotension and then was not resuscitated. So the consultant took a call, take to theatre. The bloods had come at 5 o'clock, they took to theatre at 7 o'clock and they hadn't seen bloods.
Okay, but the crux of the thing is, today's thing is, don't just just don't stop there. Think further. Okay.
Yeah. I was thinking, since we've discussed, say, pancreatitis, since we've discussed some hemorrhage, shall we make sure that the other emergency scenarios include appendix, one, say, colorectal, and, the other things?
I'll make them. I'll make few, and let's discuss on the Wednesday. Yeah?
Cool. Sounds good.
Sure, Sandil. Thank you. Thanks all.
Thank you.
I don't know whether
we keep it to an hour on Wednesday?
Yeah, sure. Yeah, we have crossed more than 3 hours, isn't it?
Yeah.
I think we'll have to
Let's meet on Wednesday.
Timing a little more predictable, guys. Otherwise, home it will be difficult.
Thanks, Adil. Thanks, Akib.
Thanks, Adil. Thanks, Varun. Thank you.
Take care.
Bye.
Thanks for other people, those who joined. Murtaza, and no, thank you.